To Brain Day 2019. I'm Rich Easton, the Chief Executive of the Neurological Foundation. Welcome you to our wonderful day of talks, events and community groups in association with the Centre for Brain Research at Auckland University. My pleasure today to introduce a couple of the speakers, but just before I do, I'm going to talk a little bit about the Neurological Foundation and what we do. Couple of things, housekeeping. If we need to exit, there's exits down the bottom and up at the top, and the toilets are out of the door and to the right. If there's an emergency, there'll be warning lines, so tsunamis, avalanches, etc. Just please exit gracefully. And please remember to turn off your phones or put them on silent, because there's nothing more embarrassing than being the person that everybody looks at halfway through a speech. So the Neurological Foundation was formed about nearly 50 years ago, and we were set up to support two things. One, funding research into neurological conditions, of which there are over 1,000 different types of neurological conditions. And secondly, to provide education and awareness about those conditions back to the people in New Zealand. And today is all around helping us to send the messages about what is going on in the research world. There isn't any choice sometimes around neurological conditions. 1 in 5 people can be impacted them, and I'm pretty sure everybody will know somebody that is impacted in some way, shape or form by a condition, be it from migraine, Parkinson's, Alzheimer's or stroke, to many others as well. So funding research and the work that we do, helping the researchers here and in Otago, is really essential for finding ways to develop cures, or hopefully actually find ways of improving quality of life. Last 5 years, we've funded about $13 million of research across the country. The demand was about $45 million. We just didn't have enough money to fund all of the applications that we had along the way. So a lot of really important things going on. We also are really proud to be the supporters of the Neurological Foundation Human Brain Bank, which is actually based in this building. The team that Sir Richard Faull leads, managing brain tissues that people donate for researchers to be able to use. And secondly, we also fund the Chair of Clinical Neurology. We just re-entered into another 5-year relationship with Professor Alan Barber and the team which Cathy actually works within as well. So this month for us is all about our annual appeal, helping to raise money to support and continue the wonderful work that the researchers do along the way. And today it's my real great pleasure to introduce Professor Cathy Stinear. Cathy is the chair of our Scientific Advisory Committee and is also doing some amazing work around stroke. So she's going to talk to you, and then we'll have some time for questions, and there'll be runners, and we'll close at the end. So I'm just going to put up Cathy's slides, and please join me in welcoming Cathy.
Kia ora, Rich. Kia ora, Rich, and tēnā koutou katoa. It's great to see you all here this morning, and today we're going to be talking a little bit about how we are revolutionising stroke care in New Zealand. And before I start, I'd just like to acknowledge some of the organisations that have supported the work I'm going to tell you about: the Neurological Foundation of New Zealand, the Auckland District Health Board and the Health Research Council of New Zealand, and also, very importantly, my colleagues and collaborators, Professor Winston Byblow, Dr. Marie Claire, Professor Alan Barber and Dr. Suzanne Ackerley. They're all absolutely instrumental in the research efforts that I'm going to tell you about. I'm just the really lucky one that gets to come out here and share their stories with you. So stroke, what is this? Well, stroke is actually the most common cause of adult disability worldwide. This is a massive problem. There are around 8,000 people who experience a stroke in New Zealand every year. And at any point in time, there are roughly 56,000 people living in our communities living with the consequences of stroke. And of course, those consequences aren't just confined to the people who've experienced the stroke, but to their family, their loved ones, and their communities as well. The rather alarming thing is that we expect around a 40% increase in these numbers over the next 10 years. So we've got a lot of work ahead of us. Now's the time to be significantly improving the way that we care for people who do experience stroke, and preferably just trying to reduce that increase, if that makes sense, as much as we can. So what exactly is stroke? Well, the simplest definition is that it's the acute onset of a neurological deficit that persists for at least 24 hours. And this results from a disturbance to the brain's blood supply. Now, most stroke occurs because there's a blockage in an artery supplying part of the brain. So that's what we call an ischemic stroke. A clot forms somewhere in the body, and it will move through the arteries, and those vessels get smaller and smaller and smaller, and it'll eventually find a vessel that it will not be able to pass through. So it blocks the flow, and so the tissue downstream is deprived of the oxygen and the nutrients that it needs. When that happens, it's been estimated that we lose cells in the brain at the rate of about 2 million per minute. So it's fast. These are very vulnerable cells, and they don't last long when their blood supply is severely compromised. The other 20% is called a hemorrhagic stroke, and this is where a blood vessel leaks or ruptures. And it's a similar effect because the blood that should be flowing through that vessel to the downstream tissues can't really get there because it's busy leaking out directly into the tissues, and it's not as useful that way. So, same thing happens. The downstream tissues are deprived of oxygen and nutrients, and those cells quickly begin to die. So time is brain. You just get 2 million cells a minute. So the catch cry is time is brain. Does anyone know the acronym for how to recognise the signs of stroke in you or someone you're with? And I'm not looking at you, Don. That fast? Fast. Excellent. What does the F stand for? Face. A is for arm, S is for speech, and T is for time. Excellent. If you just don't remember a single thing that I say today, I'm totally fine with that. Try to remember this. This is the most important thing that I will share with you today. Fast. If any one of these symptoms is apparent in you or someone you're with, call the ambulance. Don't wait for all three. You don't need all three. You only need one to call the ambulance. Tell them, I think this is a stroke, and let's get going, because time is brain. We'd far rather you turned up at the hospital, did some tests and worked out, oh, actually, no, that's not a stroke. Phew. Then if you turn up the hospital saying, oh, yeah, this started yesterday and I called my GP and he couldn't see me till the next day, but it's gotten a bit worse, so I thought I'd better come in. It's too late. Okay? Too late for what? Well, as I said, we've got these two big types of stroke, hemorrhagic and ischemic. Just to illustrate these a little bit better, because it'll help you understand the next part, this is what a hemorrhagic stroke commonly looks like. So some of these really small arteries deep inside the brain give way and the blood leaks out into the tissue. An ischemic stroke is where we have a blood clot like this, gets stuck in a vessel, and so sometimes that affects these small arteries deep inside the brain. Other times it affects these much larger arteries, and then it's quite large areas of brain that are affected. So lots of different types of stroke. I'm going to focus in this next part on the ischemic type, mainly because that's the most common type, and that's where a lot of really major improvements in stroke care have recently happened. How do we avoid having a stroke in the first place? Hearing from you. What are some good ways to reduce your risk of stroke? Diet. What about your diet? Fruit and vegetables. Exercise. Why exercise? What does it do? Gee, I'm pushing you, aren't I? Yeah. Diet and exercise. So you're right, you're absolutely right. These are all part of a really healthy lifestyle, but we need to think it through a little bit further about how it's going to affect our blood. Because ultimately, strokes are caused by problems with the blood and the blood supply. So we need to link it back to the blood. Anyone got any other thoughts? Blood pressure, excellent. Hypertension, high blood pressure is one of the leading risk factors for stroke. So making sure your blood pressure is well controlled and as low as you can kind of safely manage, that's a good idea. And there's simple things you can do, like just thinking about the amount of salt you add to your food. Right? That's a diet example. What else have you got for me? Cholesterol, excellent. So cholesterol leads to the formation of plaques, right? So sticky substances that stick to the inside walls of your arteries. Those promote clot formation, a thrombus, which can then break off and head north into one's brain. So yes, being really careful about managing your cholesterol levels is really important. And that is helped by diet and exercise. And sometimes that's not enough, and medication is also needed to keep those levels at a sensible range. What else you got for me? Biggie, no one's mentioned. Atrial fibrillation and smoking. Yeah, those are the two I was expecting. So, well done. So smoking, absolutely, is a major risk factor for both types of stroke, actually, ischemic stroke and hemorrhagic stroke, because it changes the blood and it also damages the linings of the blood. Marijuana, oh boy, yeah. We're going to have a big Q&A at the end of this, so I'm going to park that and we're going to come back to it. Atrial fibrillation, though, came up over here. Yep, so atrial fibrillation is where the heart is not kind of quite beating with a normal rhythm, so that it should be the top half, then the bottom half, so lub-dub, lub-dub, lub-dub. And instead, this top part up here, the atria, are sort of shivering instead of giving a nice, sensible, rhythmic beat. And what that does is it predisposes to the formation of little clots, which can then, again, go north and cause harm. Right, so there's not a lot you can do with your lifestyle choices about atrial fibrillation. That needs to be medically managed, right? But there are things you can do about those other things, like your blood pressure and smoking and cholesterol. And another one is diabetes, actually. So the things that you can be thinking about: make sure your blood pressure is in a sensible range. Do whatever you can about that. Don't smoke, ever. Don't start smoking. If you are a current smoker, get the support you need to try to quit. It might take several attempts, and that's okay. Lower your cholesterol if it's a bit high, right? And that, like I said, sometimes diet and exercise are enough, and sometimes they're not, and medication is also needed. Control diabetes. Uncontrolled or poorly controlled diabetes is another risk factor for stroke, because diabetes, again, damages the linings of blood vessels, and that creates problems. And just overall, get regular checkups. Doesn't hurt. And you might be thinking, well, gosh, I'm young. I'm going to start thinking about this when I'm a bit older. Stroke happens at any age. And a third of the people we see with stroke are of working age. They're under 65. The people in our research are as young as 18. So it can happen to any one of us. So it doesn't hurt, does it? To think about your lifestyle choices, your blood pressure, and your cholesterol at any point in your life. Okay, so how do we treat it? Despite our best efforts with prevention, the stroke has still happened. Well, people who have an ischemic stroke, remember there's a clot stuck in there. I showed you a picture of that before. The idea is to get rid of that clot and restore normal blood flow back to the area of the brain being deprived. There's a medication that can be given intravenously called TPA, tissue plasminogen activator, and that is a clot-busting treatment. It's a very powerful drug, right? And so it can be administered, and it circulates around the body, and we hope enough of it finds the clot in the brain to dissolve it down and restore natural blood flow. The catch with it is that it does need to be administered within 4.5 hours of the stroke symptom onset, which brings us back to time as brain. Okay, think about that. The person you're with, or you, think you might be having a stroke. By the time you've called the ambulance gets to you, they get you to hospital. You can't just have this as you walk through the door, because it's a very powerful drug, and there are some people for whom it would be very dangerous to have this kind of treatment. So they have to check it all out. They have to check you out. They have to check your medical history. They need to do a lot of quite sophisticated brain imaging to know that this is a safe and appropriate thing for you to do. All of it takes time. Right, so that's why you have to get on with it and call the ambulance straight away to give yourself a chance of having this treatment if it's appropriate for you. What happens when we get the stroke? So this is 100 people, and the dark green people are people that are now able to function normally or fairly normally, who wouldn't have otherwise been able to do so if they hadn't had the drug. Right, so that's about 13% of people having this drug do a lot better than they would have otherwise. The light green people means that they're better. They're definitely better, but they're not sort of getting back to near normal. At this end, we have a couple of people who are actually made worse by this drug, and one who is actually severely disabled or even passes away. Like I say, this is a very powerful drug. So, yes, for some people, this medication makes a massive difference to their life after stroke. But there's a big group, isn't there, for whom it really doesn't make a difference. They're going to land where they were going to land. So what can we do with them, for them, to help them have a better outcome? This is where clot retrieval comes in, and this is Professor Alan Barber, who, as Rich said, is the Neurological Foundation Chair of Clinical Neurology at the University of Auckland. He's a stroke specialist neurologist, and it's my great pleasure and privilege to work closely with Alan. So I'm showing you Alan because he really led a study that was conducted here in New Zealand into clot retrieval, and it was one of several large international multi-site trials that were all published at the beginning of 2015. That was a banner year for stroke here around the world. I'll show you why. Clot retrieval looks like this. Well, it doesn't look exactly like that. This is an angiogram, and it's showing you blood vessels in the brain. What you can't appreciate yet is that there should be a bunch of squiggles over here on the right, and there's not. And that's because there's a big clot sitting here, and it's blocking the flow. So what the interventional neuroradiologists and neurology team can do is put a catheter into the groin, squiggle up into the brain. Don't worry, you're asleep for this, because it just sounds awful. You don't know anything about it. Squiggle up, and you can actually see the wire here. Can you just make out that little thin silvery line? And you can see some of this is coming back, and here it is, blood flow restored. Wow, I know. So, I still feel amazed when I see this. And this is what they're doing routinely now. Apologies for the squeamish. They then pull it back out. This is what it looks like, right? So it's actually a little cage that they put in. It's called a stent retriever. So they put this thing and they open it like an umbrella, and that traps the clot, and they're able to pull it all the way back out. I like to tease Alan. I say this is just really advanced plumbing. You're just unblocking pipes. He's got a good sense of humour about that. But it is absolutely remarkable, and it has revolutionised the way that people are treated in that hyper-acute stage of stroke. So now, people who are appropriate for this treatment, they get to hospital hopefully in time, all that advanced imaging is done, they give EPA regardless to get things going, then they take them to the radiology suite and try and get that clot out. Now, small clots that have found their ways into really small vessels, not really amenable to that. This is the big clots sitting in the big vessels. And this isn't appropriate for all patients, and TPA is not appropriate for all patients. So there's still a large proportion, the vast majority of people with stroke actually don't receive these treatments. But for the ones who do, it can be absolutely life-changing. So far, to the end of 2018, at least 491 people in New Zealand have been treated with this. You can see that the bulk has been here in Auckland. That's simply because Auckland started first, because the research was done here, so it was very easy to get going quite quickly on doing it in real clinical practice. And Alan has worked tirelessly to support teams in Christchurch and Wellington to build their capacity for delivering this important treatment for people in their region as well. So those numbers are going to go up across the board. And thankfully, we're a small country. And so that means that even though just at the moment we've only got these 3 main centres offering clot retrieval, you can see that most people are within 2 hours to 90 minutes of a hospital that can make this available to them. So there's a lot of helicopters flying around now with people looking for clot retrieval. So that sounded weird. So Auckland now offers this as a 24-hour, 7 days a week service. And we look after patients, as you can see, from Taranaki north. So far in New Zealand, 500 people have been treated this way, which means that statistically we know there are probably about 192 more people who are now less disabled as a result. 100 more people who were able to go home and be independent as opposed to having to stay in a care facility and be dependent. And about 80 more people who have avoided hospital level care. So for this 500 people, this investment in developing this treatment has been completely worthwhile, and it will continue to be completely worthwhile for communities throughout the country. So, Clot Retrieval, now available in New Zealand. We're very proud of that. Actually, there was a time there, I think in 2016 to 17, where we were doing more clot retrievals than London, right? Simply because we had the infrastructure already in place. But as I said, not all patients are eligible, and actually most do still experience some disability. It's not the miracle cure. You don't walk out clicking your heels back to normal, but you are markedly better off for having this treatment than if you didn't. So I hope I've shown you that stroke is caused by problems with the blood, and the acute treatment, which we've been talking about, is about the blood, unblocking pipes mainly. And prevention is about the blood. All of those things we talked about to lower your risk factors are about your blood. But recovery is about your brain, right? Recovery is about how does the brain adapt to and compensate for the damage that it has sustained. And this is where I come in. I'm the brain scientist. So I like to tease Alan and call him the plumber. I'm the electrician, because I look after the brain. We're fine, we've got it covered. All right, so one of the real challenges in stroke rehabilitation is that people who look very similar at first can have very different recoveries and outcomes. So this is a graph showing you 40 people. It's research we published a long time ago now, but it's still instructive. You can see that as a group, people tend to get better over time. But if you look at the different lines, and they get to different places and so on. So this is just a functional measure called the ARAT, which is how well people can use their hand and arm. 57, many of us today would score that. And we measured them within 2 weeks, again at 6 weeks, 12 weeks, and 6 months after the stroke. So here's a pair of people who start in a similar place, roughly halfway on the scale. One person actually does pretty well, and by 6 months, their hand and arm function is almost at a full score. But the other one, not a lot of improvement after that time. Here's another pair of people who started out with more severe impairment. One had this spectacular recovery, the other was more gradual and more modest. I think the people that really trouble us clinically, are these people who within a couple of weeks after their stroke have really no meaningful movement of their hand and arm, and yet one of them can go on and actually make a pretty decent recovery, and the other one won't improve. And the problem for us clinically is that we look at them in the bed, not the same bed, 2 different beds, right? Just for clarity, if we just look at them, they look the same in terms of what they can and can't do. And that's hard to know what to do then as the therapist. And the person who's getting better, it would be easy to think, I'm doing a great job as a therapist. And the person who's not improving, that really knocks your confidence as the therapist. What am I doing wrong? Have I chosen the wrong treatments? Am I not doing enough? Why are these 2 people, and I'm giving them the same care, and one's doing great and the other one's not improving? Right? It's hard for therapists to manage that level of uncertainty. So we think that brain biomarkers could be pretty useful here, and we think that the function of key pathways between the brain and the hand and arm might hold some of the answers for us. So one of these biomarkers we obtain using something called transcranial magnetic stimulation, or TMS. This is a safe and painless and non-invasive way of testing those connections. It's pretty simple. You activate the movement part of the brain here on the side that's had the stroke. You put sensors on the arm that record very low levels of muscle activity. You see if we activate here, do we get a response here? Right? It's not neuroscience, actually it is. But it's very simple. It's very simple. Another way we can look at it is to look at those structure of those key pathways with MRI scans, and I've just highlighted for you here in blue the main cables that take commands, movement commands from the brain down to the spinal cord and then out to the body. A couple of ways we can do it. We've put these together into something called the PrEP2 algorithm, and I'm not going to spend a lot of time on this, we'll just whisk through it. It starts within 3 days of stroke, and it starts with the physiotherapist just evaluating strength, how strong a couple of key movements are. This movement, shoulder abduction, and this movement, finger extension. Those are each graded out of 5. This is a 2-minute job at the bedside. The scores are added together for a score out of 10. And we know that people who have a score of at least 5, 3 days after their stroke, and they're young, which is in stroke land means you're under 80, that's young, then these people are most likely to have an excellent outcome for their hand and arm within 12 weeks. They're going to do pretty well. If you are a little bit older, over 80 or more, you need a higher SAFE score. You need better movement initially to achieve that same outcome. You need a SAFE score of at least 8. If it's not, if it's 5, 6, or 7, you're more likely to have a good outcome for your hand and arm at 12 weeks. 2/3 of our patients come through this top half of the algorithm. So by knowing the age and this quick bedside test, the therapy teams can give a pretty accurate prediction at the beginning for what that person can expect for their hand and arm movement down the track. The other third of people are more affected by the stroke initially, and so their SAFE score is less than 5 at 72 hours. Now we need this TMS test to check the connections between brain and hand. The therapists do this themselves. It's no longer part of research. It's part of routine clinical care. And they're looking for this, which is a motor evoked potential, or MEP, to see whether or not that we can get a message through. If we can, then again, that person is most likely to have a good, possibly excellent outcome. That's great. This is an exciting part of the job because these people often have no movement at the time of testing. And it's rewarding to be able to say to that person and their family, look, we know that things look pretty grim at the moment, but the connections actually still work. So you've got good potential, so let's go. Let's see how far we can get. Unfortunately, roughly half of the people who have this test don't have responses to the stimulation. We can't get a message through, and that signifies severe damage to those key pathways in the brain. Now it depends on their overall stroke severity. If their overall stroke severity, just using the standard clinical scale, isn't too bad, higher scores are worse, so a low score is good. So under 7, they're most likely to have a limited outcome for that hand and arm, but if the overall stroke is a bit worse than that, they're most likely to have a poor outcome. You can see that the accuracy for these two predictions is actually quite high, 85 and 90% accurate for these groups. The reason that these two groups can't do as well as these two groups is that they're not going to get fine control of that hand back, because that key connection that we're testing is responsible for fine control. And unfortunately, when it's broken, we don't have any therapies or treatments that can repair it. It's broken. Right? So they may well get some movement back at the shoulder, maybe some movement at the elbow, and therapy is designed to help them make best possible use of that. Right? So everyone gets therapy here, it's just that the goals need to change depending on the brain's physical potential for recovery. The focus for the rehabilitation, as I said, has to differ between these 4 groups, but everybody gets therapy. That's really crucial. And it's also important to understand that we're only talking about hands and arms. We're not talking about walking and balance and talking and swallowing and thinking and organising. All of those other things can be affected by stroke too, right? And this prediction tool is just for the hand and the arm. So we have to keep it in perspective. So we've tested this before it went into clinical practice to see what happens when you use this in the real world. We found that this information gave therapists more confidence. They had a better sense of where to go with their patient. It resolved some of that uncertainty I was telling you about before. This enabled therapists to give more focused therapy, which was tailored to the recovery potential of individual patients. And we think that contributed to people leaving hospital sooner because the therapy better met their needs. And that's a good thing. Well, certainly the bean counters like it, but patients and families like it too, right? People want to go home. You don't want to spend weeks in a hospital. So overall, we think that having this information probably increases rehabilitation efficiency, and we weren't able to detect any negative outcomes of that for the patient, their satisfaction, or how well they actually did. I'm just going to completely switch gears here for a second and talk about walking for a second, because at this point, everyone goes, that's great, what about walking? Walking is also very important. 60% of people with stroke need help to walk after their stroke. And independent walking is the most frequent goal. If you ask people after stroke, they will most commonly tell you, I want to be able to walk by myself again. It's a really important goal, understandably. So I'm just going to show you quickly some work being done by Dr. Marie-Claire Smith, who's a neurological physiotherapist and a postdoctoral fellow supported by the Neurological Foundation in our group. She's done some cool stuff. She's interested in making predictions about walking after stroke, because your ability to walk determines both when you get to leave the hospital and where you go. Are you going home? Are you going into a care facility? What level of support will you need depends a lot on how well you're able to walk by yourself. Can you walk by yourself? So she's come up with this walking prediction tool called Twist, which we're currently testing in a validation study across the road in the hospital. It's much simpler than PrEP 2, which is great. The first test is simply how well somebody controls their trunk. And this is, again, it's a relatively short bedside assessment that therapists can do quite readily. High scores are good. So if people are scoring more than 40, they will most likely be walking by themselves, no supervision needed, quite fine, thanks, within 6 weeks. We've seen people with no movement at all in their weak leg a week after their stroke, and they are walking safely on their own within 6 weeks, provided they've got good control over their trunk. That's great. Again, it takes out so much uncertainty. However, if their trunk control is not very good, then we have a look at how strong their hip extension is, which is this movement. It's putting your leg back behind you, right? That's hip extension. Again, it's graded out of 5, and if people score at least a 3, they will be walking on their own within 12 weeks. If they don't, they will not be walking independently at 12 weeks. So we think this is important because we need to know not just whether someone will walk by themselves again after stroke, but when. When are they likely to get there? This really is helpful to families in particular, thinking about, well, how much support is Dad going to need at home? Is someone going to have to move in for a few weeks? How many weeks? Are we talking a couple? I could get a couple of weeks off work. But if we're talking 6 weeks, well, okay, we're going to need a different plan, right? So thinking about those options, thinking about, do we sell Mum's house? Or is she going to be able to live in her own home again after all of this? So the value of this information, we think, is quite high. The study we're now doing is looking every 2 weeks to try and give a more fine-grained prediction, which we think will be even more useful. So what have we achieved so far? Well, I hope I've shown you that certainly here at University of Auckland, through Professor Barber's work, we're leading treatment of acute stroke and leading the way for the rest of the country. And it's incredibly rewarding to see that now available to people throughout New Zealand. We're also developing these prediction tools for hand and arm recovery and walking recovery. And we're publishing this in some of the best journals around the world. And so we're garnering a great deal of international attention for our work in these areas. PrEP 2 is now being looked at in several hospitals around the world, both in research and putting it into clinical practice. And so I had no idea, I could not anticipate how much of my working life was actually going to be diverted towards supporting hospitals in various parts of the world as they figure out how to do this in their environment. So it's great that here in New Zealand we've created something that the rest of the world puts a lot of value on and wants to use in their own practice. So how on earth have we done all this? Well, I think we've achieved these successes by doing our research in the hospital. We're very privileged. I consider it personally a great privilege to work with people who've experienced stroke just in the last day or two and their families. They're going through something really difficult and they're so willing to help us create new knowledge so that we can help all the people coming along behind them. It's very humbling and very rewarding. The great beauty of doing the research in the hospital, in that clinical setting, is that it reduces the time lag between the discovery and it actually being used in clinical practice. Because if you can do the research in that environment, you've actually solved most of the problems about then doing it for real, like not as part of research, but as part of routine care. So can anyone guess how long it typically takes for a new discovery to make it into widespread clinical practice? How long? You're going to have to speak a bit louder. 3 years? 7 years? 5 years? Any advances? Going to sit around there? Okay. Try 17. I know. It's shocking and sad. Think of all the people in that time who could be helped. It's shameful, actually. I'll get back to that. You'll be pleased to know that these acute stroke treatments I've described and the PrEP 2 algorithm that is now practice across the road have made it into practice in 18 months. That's more like it. That's what we're talking about. Why? I think there's lots of reasons why we've been able to shorten the gap. The key thing is we're doing the research in situ. We're doing it where it needs to be used. And we're very fortunate to collaborate with amazing clinical teams in the Auckland District Health Board who are really excited about improving the quality of their care, and they're welcoming this work into their practice. So we're very, very lucky here. What next? Well, we plan to continue building clot retrieval capacity throughout New Zealand at other hospitals so that it's readily accessible for everyone, including those people down in Fiordland. You'll notice no helicopter coverage down there. Don't do this on the root burn track. Okay, and we're implementing the PrEP2 algorithm in practice in hospitals throughout New Zealand and around the world. And we're busy validating and implementing the TWIST algorithm for walking, both in practice here and around the world. We're also continuing to build our group. We're training and supporting the scientists and clinicians of tomorrow. And these are just some of the amazing people that we've worked with along the way, because ultimately, teamwork makes the dream work. Thanks. Remember this thing you need. And we have a few minutes now for your burning questions. If we have a couple of young men here who will help, because this is being live streamed, we do need to hear your questions through a microphone. So don't attract my attention, attract the attention of these two young men, and they will bring you a microphone to ask your question. This lady here had her hand up first.
You didn't actually tell us what a stroke looks like. Is it just a big faint on the floor?
No.
You didn't
Thank you.
Yeah.
What a massive oversight on my part.
What happens? In a stroke?
Let's back up. Okay. I have to fix my slides. So a stroke can look like many, many different things, and that's why it's hard to just give you an instant mental picture. But I think these three things are key features to look for. And as I said, you only need one to suspect that you or someone you're with is having a stroke. Right, so a droopy face down one side. If you ask them to smile, only one side goes up. Can't lift both arms. A leg might give way, right? Weakness in one leg. Or they can't speak a full sentence or find their words, right? Or their speech is really garbled. Any of those things mean call the ambulance. Loss of consciousness is actually uncommon with stroke. Most people don't lose consciousness. And the worst part is, it doesn't hurt. If it hurt, people would do something about it much more quickly. The good news, it's not really good news, the good news about heart attacks is that they're very uncomfortable, and people know something's really wrong here and they ask for help quite quickly, right? But your brain doesn't sense pain that way, even though it's kind of the same event, isn't it? Heart attacks and stroke is very similar, a loss of blood supply to a vital organ, but one hurts and one doesn't. The eyes can certainly be open. They can be looking at you holding a conversation. I've seen video footage of a GoPro of a friend of my husband's who had a stroke while riding his motocross bike. Yep. And so it's from his helmet view, and you can see he comes off his bike at slow speed, he picks it back up on the dirt, kids are zooming past him, and he's trying to get his hand up onto the handlebar. And you can hear him frustrated and confused by this. Why can't I get my hand up to the clutch lever to get... So, yeah, anytime. Yeah. Over here? Or over here? I don't know where to look.
Hi, I was just wondering how stroke...
So stroke at a younger age is sort of interesting because the brain is still developing and changing. So a little bit depends on how young, right? So stroke can even happen before birth, and that can give rise to things like cerebral palsy, for example. And it can happen at any time in your life. Obviously, young people with stroke have not had a stroke because they've had a lifetime of cigarettes and pies. They haven't had time for those sort of lifestyle factors to kick in. So stroke in young people is usually due to other things that they were born with, like maybe a heart defect or a defect in the way some of their blood vessels formed in their brain. However, stroke in young people has very similar effects to stroke in older people. Sometimes stroke in younger people, depending on how big the stroke is and where it is, because the brain is still developing, it has some time to adapt a little bit better. So sometimes the outcomes can be better, but certainly not always. Yeah. I think it's a fascinating field of inquiry, and my colleagues overseas are doing beautiful work on this. Yeah.
Sorry. Thank you. The question was just to follow on the one you just, before this one. Can you have a stroke in your sleep.
Yes,
And
absolutely. Wake-up stroke, that's called. That's
Thank
really
you.
tricky from a clinical perspective because I gave you some time windows for when the clot-busting treatment, the drug, is useful. So what happens if you hop into bed at, let's say, 10, let's say you're an early to bed, early to rise kind of person, you hop into bed at 10, you're asleep by 10:30, feeling fine, and you wake up the next morning about 5:30, and you go to get out of bed and one side of your body isn't working properly. When did you have the stroke? Was it 3 minutes ago, 3 hours ago, 6 hours ago? It's very hard to know, right? So clinically, that's extremely challenging. And so we talk about time last seen well. When was this person confirmed as not having had a stroke yet? What time was that? And things are based on that. There's some important work being done to see if imaging can be used to estimate how long ago was that stroke probably, in the hopes of being able to help more people who with wake-up stroke. That issue is more critical for the drug than it is for the clot retrieval. The clot retrieval can be done a bit later, if it needs to be done a bit later, which is why in a regional hospital they might get the drug going and then pop them in the ambulance, bring them to Auckland, and then they'll take the clot out, so they don't have to happen sort of instantly together. But obviously, the longer you leave it, the more damage has been done. Yeah.
I have two questions. First one is, what is the difference between a stroke and a TIA?
Yep.
And number two, is there a time limit for clot retrieval, absolute time retrieval?
Yeah. Okay, excellent questions. The differences between a TIA, so TIA stands for transient ischemic attack. Sometimes people call them a mini stroke, you might have heard that. So these are situations where there has been usually a little blockage. It's more common that it's been a little blockage than a little bleed. A little blockage somewhere that creates some neurological symptoms, and then they resolve because maybe that clot breaks down on its own, or it's so small that you're able to compensate for it. Right? And TIAs aren't candidates for the sorts of acute treatments I've been telling you about, the drug or the clot retrieval, because it's all too small and it's happening very quickly. Most people with TIAs, by definition, feel that they get back to normal. The issue with TIAs is that it's telling you and your doctors that you're at a much greater risk of a stroke, right? So they need to be taken very seriously, and people need to be really carefully evaluated to make sure everything is being done to lower their risk of a major stroke. So we have a good system in this region for caring for people with TIAs to minimise the chance of them having that big stroke. But it's always disappointing when somebody comes in and says, oh yeah, I've had these couple of funny turns and I went and saw my doctor, we thought it was probably okay, I had 2 of those last week, and now they're in with a massive stroke. And maybe if that had been picked up and dealt with a little bit more aggressively at the time, perhaps there might have been a chance of preventing that big stroke. So they have to be taken very seriously. Just because it goes away again doesn't mean you're off the hook, is the thing to take out of that. Your second question was hard time limits for clot retrieval. They have been done up to 24 hours after stroke symptom onset, but I'm always reluctant to tell you that because I want you to be in a hurry to get to the hospital. So just delete that, all right? But in honesty, yes, they can be done quite, but the outcomes are never as good, and it's unusual to be doing them that late. Yeah. Yeah, there was a question way up the back. Runner, was there anyone closer over this side? This lady here?
Thank you. Is there a difference in the symptoms between hemorrhagic and ischemic strokes?
Not really. There's very little difference because the signs and symptoms depend on the part of the brain affected, and that part of the brain could be equally affected by a clot or a bleed. So the actual presentation is often, there's no way of knowing, which is why, but the treatment's totally different, which is why getting to hospital quickly so they've got time to do the imaging so they can see which type is so important. Clearly, if you've got a bleed happening in your brain, you don't want to have a drug that's going to make your blood thinner. No, that will take you in exactly the wrong direction, right? So this is really, again, get there as fast as you can so they've got time to get the imaging done and figure out exactly what's happening. Way up the back here.
Hi. With someone I know, elderly, that's had a stroke at the end of last year, he was told immediately to cut down on salt intake, and he has been in rest home care since. But now he's got low sodium, and I know someone with low sodium that's in their 90s, and it's so hard to handle when they've also got a catheter and things like that. So how do you deal with that when you're meant to drink, to hydrate?
So thank you. I mean, I can't comment obviously on that particular case, but it's an excellent reminder that people are allowed to have more than one thing wrong with them, of course. And the older we get, we kind of seem to accumulate this baggage of stuff that's not quite right, don't we? So by the time, yes, we're at those more advanced ages, chances are our stroke risk factors are not the only things that we have to worry about. There are probably several other things going on. And it can be a very fine line, can't it, between how do you manage to get the perfect level of sodium in your blood? Difficult. But certainly monitoring and having good conversations with one's doctor is the sensible approach, accepting that there is often no perfect solution in those very complex situations. Yeah. Down here. Sorry, I'm just kind of waving my arms around. It really depends on the runners. I don't have a lot of control over this, I'm sorry. You guys just need to go fast. Up the back. Hello.
Yeah. Hello. Thank you very much for all the useful information. I also had a family member who experienced a stroke. So he was lucky enough to have not so many physical consequences, but I know there are a lot of people who also experience psychological consequences. Sorry. Yeah. So I would like to know, how does that happen? How does it affect someone psychologically? Is it more the drugs or the structure of the brain that changes? Or?
Thank you. That is such a good question, and I always hope somebody brings this up.
Thank you.
So you're quite right. People experience a lot of things, a lot of changes in their thinking and their mood after stroke, and that changes over time as well. So it's estimated that between 30 and 60% of people with stroke will experience depression at some point in the first 5 years after their stroke. And there's a couple of ways to think about that. One is that, well, your feeling organ, your brain, has been injured, and that's probably knocked it off balance in terms of its chemistry. So perhaps there's quite a physiological reason that makes you more likely to experience low mood and depression. I also think it's a pretty natural response to something like this. I would be really concerned about somebody who had a major life event like this and just went, yeah, cool, I'm good with that. Yeah, see, that's not normal, right? So it's normal to go through a grieving process. It's normal to feel really angry and sad about what's happened and what's been lost. On top of that, people can experience difficulties with their thinking and their ability to express themselves. So now you've got these difficult emotions that you're grappling with, that you're struggling to sort through and struggling to express. So all of those things together make it really hard for that person and their family, because it should also be acknowledged that the loved ones of people with stroke go through their own adjustment period. And that includes anger, stress, sadness, grief. All of those other things happen for them too. And I think the really tricky bit is that people work through these emotions. Ideally, people eventually get to the point where they can go, okay, this is it. This is our new life after stroke, and it's not what it was before, but it's still a life worth living, and we're going to make the most of it. That's called acceptance. And everyone involved, the person with stroke and all the people caring for them and all the people who love them, we hope, arrive there at some point. But they're all going to get there at a different speed. They're all going to get there at a different time. And that mismatch can create a lot of tension in relationships, right? Some people get there way before the other people in their immediate circle. Some people don't get there at all. And so that creates a lot of difficulty sometimes for people living with stroke and their family, because they're in different places with grieving and acceptance for what's happened. So yeah, it's a real issue that we're aware of, and certainly the people, particularly in the community, like the Stroke Foundation and community rehab teams, are very sensitive to these issues and offer, I think, excellent support for people with stroke and their families. Does that mostly address your question? Yeah. Thanks.
I just wanted to say that my husband had a stroke a couple of years ago. None of those symptoms were visible. He was sitting up in the chair, but he was not responsive to me. And the thing that really chimed was tea.
Yay for tea!
I thought something serious is happening. I don't know what it is, but I better get hold of somebody who does.
Yeah.
So that was the first point.
I'm going to respond to that really quickly. You make a good point. These are simply the 3 most common signs of stroke. There are other signs of stroke which are much less common, but this is a general public education message. So we have to go with what are you most likely to see. And I would argue that his non-responsiveness to you comes in under S, speech. He wasn't responding.
No.
So no speech is just as bad as garbled speech or speech that doesn't make sense.
It's not much good looking at that and thinking this doesn't apply. It's looking at thinking this is not right.
This is not right. Trust your instincts and call the ambulance.
And
there was a part 2. Yeah.
Part 2. He had the clot retrieval.
Oh, okay. How'd that go?
So impressive. That team scrambled in the middle of the night.
Oh yeah.
And just came in, and you would not believe it.
I would.
Well.
Oh yeah.
Not being exposed to such things, it was very, very impressive.
It is impressive, and it's moving.
Yes,
it's moving for the clinical teams involved. They might sort of have that moment when their phone rings at 2:15 in the morning and they've already been back in once at 11 p.m. They've just gotten back to sleep in. We're back in again. This is 24/7. These are senior consultants all around the city. And they do it anyway, and they get in there and they absolutely give their best. And when they're tired, Alan has some pretty crazy stories about how, the lack of sleep sometimes. And when they're tired, it's still just so rewarding for them to see what a difference it can make. Not for everyone. We have to be a little bit cautious here. We're not talking magic. But for some people, it is phenomenal. And I still get goosebumps sometimes thinking about those people.
I heard about that procedure at a brain day.
Oh, there you go. And now you've heard about it, all of you, at Brain Day.
What was going on?
I think we've got time for just 1, maybe 2 more very quickly. We are going to get back to marijuana, but we're just going to answer this question here. Sorry. Marijuana, gosh, you're good. You're keeping me on my toes this morning.
When pathways to limbs are destroyed in adults,
yes,
can new ones ever be forged or developed?
No. That's the simple, short and sad answer. We don't have any treatments that can replace lost brain tissue. People are working on this. That's the good news. And I sincerely hope that within my professional lifetime, we will have something to offer that. But at this point in time, there is no treatment that we can offer that can replace those lost pathways. Once they're gone, they're gone. And so our job in therapy is to help brains and the people that own them learn to live as well as they possibly can with what they have left. And there's a lot that we can do to help that process, a huge amount. Therapy is so worthwhile, right? So you can't be nihilistic about this, but we do have to accept. It's a little bit like losing toes to frostbite. There's no amount of positive thinking is going to grow them back. It's so sad, but it's the truth. And we have to grapple with that truth and do the very best we can and continue hoping and supporting the researchers who are working to solve that problem. Marijuana, cannabis, last thing. Professor Barber actually led the world's first study showing that people who are cannabis users are at a heightened risk of stroke. A little bit to disentangle because, of course, they also have some other quite unhealthy lifestyle choices. They smoke often. So a little bit hard to completely be clear on, but certainly he was the first in the world to show that cannabis use increases your risk of stroke. This is important as we're coming up to a referendum on the legalisation of recreational cannabis. I'm going to leave you hanging on what I think about that. But please, before you vote, educate yourselves. Think really carefully and get good quality, credible information before you make a decision on how to vote in that referendum. That's all I have for you. Thank you. You've been great.
Thank you ever so much, Cathy. That was really enjoyable. I heard Cathy speak excitement every time there's something new in their story. Come back again at 12 o'clock. We've got Sir Richard Faull talking about the magic and excitement of the human brain. Look forward to seeing you again soon. Thank you. Some of you can hear me. Welcome to Brain Day 2019. I'm Rich Easton, the CEO of the Neurological Foundation. It's my great pleasure to welcome you to our day today. Just before we start, a few housekeeping things. If there's ever the alarms go off, there are exits down here and up at the top of the stairs. If you need the toilets, they're out of the top and off to the right. A quick reminder, turn off your cell phones. There's worse thing than being disturbing in the middle of the lecture. And if there are any alarms that go off for fires, tsunamis, earthquakes, etc., please just follow the guidelines of the people that from the university. Also, don't forget that during the day we've got a lot of other community group speeches going on. So if you go out of the doors to the right and then slightly round to the left, there are 2 rooms with a number of other community group speeches. They're all listed, the times are listed in the program as well. So just before we start, I wanted to give you a brief update from the Neurological Foundation. So there are over 1,100 different types of neurological conditions, then they don't discriminate to anybody about who may or may not get impacted by them. The Neurological Foundation was founded with 2 purposes. One, to help fund research into neurological diseases, and secondly, to help educate and raise awareness about the impact of those diseases across New Zealand. We were founded nearly 50 years ago, and all of the work that we do around fundraising comes from the generous donations of New Zealanders. We don't have any government funding at all. And all of the work that we fund goes into researchers working in New Zealand or New Zealanders working overseas on a myriad of different types of conditions: Alzheimer's, Parkinson's, stroke, Huntington's, and many others. In the last 5 years, we've funded over $13 million of researchers going on across the country. The sad part is that we had to say no to about $40 other million just because we didn't have enough funding to fund some of the other wonderful projects that they wanted to do. Alongside that, we have the great privilege, and we're really proud supporters of Sir Richard and his team in the Neurological Foundation Human Brain Bank. It's the 25th anniversary of us supporting that relationship. We're really, really excited that it's gone on for such a long time, and we hope will carry on for forever. And similarly, for those of you who were here a bit earlier, we also fund the Chair of Clinical Neurology, which is Professor Alan Barber. So we've just renewed that relationship with Alan and his team working on clot retrieval and stroke recovery programs for another 5 years as well. So really hope you enjoy the sessions that we have today, and really looking forward to hearing your questions and comments afterwards. So it's my great pleasure now to introduce Sir Richard Faull, who is going to talk to us about the magic and excitement of the human brain. Please join me in welcoming Sir Richard.
Whoops, going a bit fast. Okay, so it is an incredible privilege for me to talk to you today. This is the one day of the year when we open our doors and we welcome the public in to hear and see a little bit about our research, to meet some of our researchers, for all our community organisations to come. We've got over 30 community organisations who are out there just telling people how they support people with brain disease. And it's a special day for them as it is for us, because they get to not only meet you people, but they get to meet each other and they get to network themselves. And for us at the Centre for Brain Research, we're all about helping people with brain disease, and our community organisations are critical to us. And I'll tell that story. And as Rich has indicated, one of our great platforms is the Neurological Foundation Human Brain Bank, and I'll tell you a bit about that, and you'll see then why the community are so special to us and how they help us to do brain research, which is actually leads the international scene. So that's fantastic. First, I just want to start off by showing you the human brain, and there it is there. For me, this is the most marvellous, the most incredible organ in the human body. I'm a little Taranaki boy. Grew up really in a general store in rural Taranaki, and I went off to medical school and saw the human brain as a third-year medical student. And that literally changed my life. And the brain you see here, is a bit like the one that we dissected as a third-year medical student. And this particular brain is a special brain because it's been specially preserved and what we call plastinated, so you can hold it. And you can look at it. And it's non-toxic, and it doesn't dry out and so it's what we call a plastinated human brain given to us by the whānau, by the family. And that's what makes our research so special. But when you look at it, you see, and you realise, my gosh, I'm going to put this one here so you can see exactly how big it is. Turn this on. Well, it did turn on before. Get our expert man to come along. Yep. Okay. So this is the brain, you see. It consists of it's coming up. See, this technology is slightly slower than the human brain. We can replace a lot of things, but we can't replace the human brain. And so there's a right hemisphere and there's a left hemisphere, you see. And the right side relates to functions on the left side of the body and the left side to the right side of the body. And what's so incredible is the way we have this complex folding of the outer part of the brain. These are what we call gyri or folds, and they make our human brain quite distinct and quite special. And we'll go on to the next slide now, onto the presentation. I need a full-time technician just to drive this, you see. It's coming up. So to get an appreciation of how special and unique the human brain is, this is a rat brain here, this is a baboon brain, and this is the human brain. Now the rat brain, we use the rat brain for probably 99% of brain research. And it's such a useful, animal models are very important. But as you can appreciate, they don't really replace the human brain. When you look at the rat brain, the outer part of it, you see, this is what we call the forebrain. This cortex is quite smooth. And it's this part of the brain, when you go up through the mammals, has enlarged and got so complex and folded so that it fits within our skull to form this huge hemisphere of these folds in the forebrain of the human brain. And it is this cerebral cortex in particular of the forebrain with the thalamus and other areas which make us absolutely unique. Every one of you in this room, you're an expert in whatever you have done in life. And you are an expert because of your human brain. That's given you particular skills, foresight, planning, memory, all your different personality, your behavioural profiles, all the things that make you unique. That makes your human brain critical to your life. Everything you've done in life is because of your human brain. So what is it about this forebrain and these folds which make our human brain so incredibly special? This is a diagram I had drawn up some years ago with a great artist, and these little men pointing to areas which do particular functions. It's sort of schematic, but it's accurate. Just to give you a feel, we're looking at the left side of the human brain. Coming down the left side, we have a fold. In everybody's brain, this fold is there, and that controls movement on the opposite side of the body. But it controls it in a very special way. So that if you map all the body muscles here, the muscles of the face and the lips are down here. As we go back up here, we go to the fingers, we go to the hand, we go to the upper limb, and so on. You go to your thorax and abdomen. That's quite a small part because you don't do very much with your thorax. You don't write with your nipples, or you don't speak with the umbilicus, you see. So that part's quite small, but then you get to your thigh area, and go over the top, you go to your leg, and that controls the muscles on the other side. So all those movements you do, they start in this motor cortex in the most precise way. And the same is happening on the opposite side, which is the right hemisphere. It's controlling the muscles on the left side of the body. And they join together. There's fibres joining the two together so you are coordinated. And that makes you be able to do movements. Immediately behind that fold is another incredibly special fold, which looks after our sensations, the touch and pressure on your skin. And so down here, we have the same body representation as in the motor area. You've got your lips, your face, sensation here, you've got your fingers and arm and so on. It's an upside down model of the body, if you like. And so when someone kisses you on the lips, you think you feel it on the lips. You do not. You feel it right there. How do we know that? Because if this area was destroyed by a small stroke or a tumour, your lips would be numb. So just think about this. The marvellous property of the brain is that you send that sensation out to your lips, you see, although it's actually in your brain. And also at the top here, if someone dropped the brick on your foot, you'd feel it up there. But it's actually on your foot. And even if you've lost a leg, people often with diabetes, they lose the lower limb. They often may have to have, because of gangrene, they lose the lower part of one of their legs. And although they don't have their leg there, the area at the top here still thinks the leg is there. So if the nerve at the end of that stump is just knocked, they'll think, my toe's hurting. So you're still feeling it in your brain, you see. When you go to the back of the brain, this is the left side of the brain, so this is the visual area, and it's seeing the picture on the right side of out there. So the pictures here actually are projected to your external field. You think you're seeing them out there, you're actually seeing them here, upside down. And you see the colours being added to it. Why do we know that? If there's a stroke effect in this area, you're blind, you won't see, you've lost the conscious appreciation of vision, although your eye's intact. And so on, you see, and the hearing is the same. You're hearing here on the left side, consciously, what you hear in the right ear. So all these functions come together in the most beautiful, coordinated way in this cerebral cortex. That's your conscious brain. Both hemispheres are roughly equal, excepting for the fact that we find there is a difference between the two hemispheres. The left hemisphere especially has additional functions of speaking, verbal language, reading and writing. And these are present for virtually all people in the left hemisphere. Everyone that's right-handed, these verbal language functions are in the left hemisphere. And for most left-handers, it's still there too, although some left-handers, how many left-handed people here? Yeah, it's probably about 1%, 2%, up to 4%. So for you, you'll still have your verbal language functions in your left hemisphere, but they may be split for some of you between the two hemispheres and occasionally maybe in your right hemisphere. You actually got a great advantage because if you have a problem and somehow you're affected by a stroke or some damage to the cortex and your language is affected, you will recover quicker than a right-handed person will. Seems to be more plasticity in that recovery. But so what's really interesting is that it's your left hemisphere that you do your speaking with, your verbal language. And you see, we don't have this in the lower animals. We don't have the specialisation of the cortex. Language is critical to humans. We read, we write, we record knowledge, and we advance knowledge. So every single second of the day, as you learn more, humans remember that and they record it. And they advance knowledge so they can do more and more as time proceeds. We build on the shoulders of giants. Rats, cats and monkeys are doing the same today as what they did 1,000 years ago. Humans are unique. Verbal language facility. And when we go back, you see, because these language areas here and this one here called Wernicke's area, because these areas are slightly larger in the left hemisphere, this fissure is just a little bit, it's a little bit flatter in the left hemisphere than in the right hemisphere. And when you look at the inside of a skull, you can see the grooves inside the skull, the bony surface inside reflects the pattern of these gyri, but especially this lateral fissure. And so when you go back and look, as we found when they unearthed all these incredible skulls from the Africa Neanderthal man, the very earliest skulls, when they took, the brain had gone, of course, years ago. When you took plaster casts of the inside of the skulls, these brains, which were from virtually 2 million years ago, you could start groove is flatter than that on the right, which indicated that these verbal language facilities very early. On the opposite side of the brain, these particular areas are involved with what we call verbal language. That's the language of, that's non-verbal language. That's language which is not the spoken language, but the language, your body language. So when you look at someone, 90% of what you see in communication is body language. You look and you can see, I can see looking at you now, you all have different degrees of excitement or whatever. You're happy, you see, and you can read a person. If a person's in love with you, they don't have to tell you they're in love, you see it. That's body language. For better or for worse, you can get yourself into trouble, but you think it's really important. And that's critical, but also singing, you see. Singing is also, the control of singing is also in the right hemisphere. So our wonderful choir you may have heard just before the lecture, this is the Centre for Brain Research Celebration Choir. They are a choir that brings people together who have problems talking, have aphasia. Now, that means they have problems talking, often because of a stroke affecting this side of the brain, the left side, or say from Parkinson's, or somehow this verbal language function is upset and they can't talk easily, but they can sing. And so the choir takes people with speech problems and they sing their way back to health, because their singing will actually help to, through plasticity, they'll help to rewire the brain and get them talking again. And that's marvellous, isn't it? And it's actually magic. And so what our people do in that choir is just something incredible. So you see, the human brain is something which you treasure. When you wake up in the morning, you should say, thank you, human brain, for I still know who I am. I have the same memories as I went to bed with. I know what I'm going to do today. I can recognise my partner and all my children, all the rest of it, you see. You take it for granted, but really it's one of the most greatest facilities that you'll ever be given, and you're given it for nothing, and it's going to be the secret of all your success wherever you go in life. The incredible thing is that we're just looking at the surface of the brain, but of course you're able to move, you're able to feel, you're able to read and write, because there are brain cells in each of these folds. And there's around about 100 billion brain cells in the human brain. That's a lot of brain cells. So we have 9 billion people on Earth. If each person was a brain cell, and inside your brain, then you would have virtually over 10 times the number of people, brain cells, in your brain as there are on Earth. And that's how many people there are. That's how many brain cells there are. Each of those brain cells gets an input from about 100,000 cells. So you see, the brain works as a team. But most interestingly, the brain cells from, if you look at a brain cell from the motor area, from the visual area, from the memory area, you'll see that they differ so markedly. That's a cell from the motor area. Beautiful fat cell with the dendrites coming off. It's a typical big pyramidal cell which talks and sends fibres down to the spinal cord on the other side to control your muscles. Go back to your visual area at the back of the brain. The cells are so very different. They are smaller. They have this huge maze of radiating dendrites. And they turn your impulses coming in through your eye, through the optic nerve, into pictures in your mind. So the picture you see out there is being turned by these cells into a picture of reality and gives you colour and all the rest of it. And if you look at the memory area, these are the cells which are responsible for playing a vital role in keeping your memories and putting your memories intact from one minute to the other and expanding your memory base. And you put that all together and you have the human brain. And I've just shown you 3 different types of cells. They vary from virtually over all of the areas. They are purposely built and made to do this marvellous job of looking after your conscious mind. So for me, that makes me want to come to work every single day and makes it exciting. So the brain having so many cells, it needs to be looked after. It needs to be continuously supplied with blood. And so it has a special pipeline coming up the side of the neck here called the internal carotid artery, which comes up in branches to supply all those parts of the brain. Now, the brain only represents 2% of your body weight. It's quite small, 1,400 grams about. And yet, it gets 1/5 of your blood supply. And it's the top priority. This is, the supply of blood to the human brain is critical. And it's not just a pipe which comes up and sends blood vessels out and to supply the brain, but it actually, each of those little vessels monitor and change their calibre, their size, on a second-by-second basis according to which part of the brain you may be using more than any other part. So if you're looking at pictures, if you're moving, this part here, or feeling kisses on your lips or whatever, all the different parts of your brain are active in different ways at different times. And so the blood supply varies up and down in the most intricate way, which we still don't understand, but it's marvellous. And of course, if one of these branches get blocked by some sort of thrombus, or because the walls are thickened in atheroma and the area supplying it no longer gets enough blood, that area will die, you see. And if that area dies, then you end up with a stroke, and that stroke may affect an area controlling movement or sensation on the other side, or it may affect writing and reading, so whatever. So the symptoms of a stroke are due to, generally speaking, due to blocked blood vessels providing a particular area. And that's, in a few minutes, the marvels of the brain. And that's something which you don't have to worry about because it looks after it. It looks after itself. You know, having these things, keep the blood supply going, do this, it does it, and you don't have to remind it. The incredible thing is that, and the great challenge for us, is that the brain is affected by diseases. Up until a few years ago, the figure we normally use was 1 in 5 people in New Zealand are affected by brain diseases. Now, with the ageing population, the figures have been redone recently by Professor Valerie Fagan, and it looks like we've got, probably because of the ageing population, there's about 1 in 3 New Zealanders, and some would argue even 1 in 2, who will be affected during the course of their life with brain disease. And these are just some of the diseases which are quite common disease. Alzheimer's, Parkinson's, and some Huntington's is quite rare. And so this is just some of the diseases which affect the human brain. And for us, of course, what our mission in life is, we want to try and help people with brain disease. We want to try and slow down the disease, stop the disease if we can, cure it if we can. This is just to show you, for 3 different diseases, we got over 70,000 people in New Zealand affected with Alzheimer's disease. And this just shows you the difference between a normal brain and a person who died at the age of 65 with Alzheimer's disease, you see. And you can see that the folds here are shrunken down, they're thinner, and especially in the memory area here, especially in the area involved with behaviour and with personality and higher cognitive functions and so on. This brain would be about 1/3 the weight of this brain, and that means about 30 billion brain cells which had been lost, and this person died at 65 suddenly from what's called a pulmonary embolus. It was not at the end of their life in terms of the Alzheimer's disease, a 6-year history, you see. And that's how many brain cells are gone. So in all these diseases, we've got to get in early and try and stop and slow down that cell death. and we've got special clinics which we're trying to do that with now. And Parkinson's, another tragic brain disease, affects the midbrain here. If we take a little slice through the midbrain, you can see on the normal side from a normal person who died without Parkinson's, we have these beautiful pigmented cells which make dopamine in the midbrain on each side. It's called the substantia nigra. And a person with Parkinson's disease, they have lost these cells. And initially, before they develop symptoms, they may have lost up to 50 or 60% of cells on one side before they actually show the overt symptoms of Parkinson's disease. Then as the disease progresses, of course, it ends up having a more dramatic effect and may even go and affect the other side too, as in this particular case. Again, in that case, we've got drugs to treat for Parkinson's, but we don't have any drugs right now that can slow it down, but we're trying to work on that. Huntington's disease is a very different disease caused by a gene. There's a gene on the tip of chromosome 4. This is a section through a person who died without a brain disease, showing this beautiful basal ganglia, and this shows a section from a person who died with advanced Huntington's disease, and they show very marked atrophy, shrinking of the basal ganglia, which causes all the terrible symptoms. That is caused by this one particular gene, chromosome 4. It's called the Huntington gene. And if a mum or dad has that disease, has that gene, they'll get the disease, and the chances are that they'll pass it on to 50% of their children. And that's the tragedy of it. But I'm going to tell you in a few moments, we have just over the last year, suddenly there's a hopeful area coming out of research where we may be able to help people who have that sort of genetic brain disease. And so when I started research back as a young medical student, it's been a year, took a year out as a third-year medical student after seeing the brain, I did a year's research on the rat brain. That was incredible. Found a new pathway and connecting up the thalamus with the basal ganglia, and it was the most incredible day of my life, year of my life. In that same year, I not only met the first love of my life, the brain, but I met the other love of my life, Diana, tucked away in the corner. Of course, she's always number one, and I go there. Okay, so and I was so captured by brain research that I wanted to continue, and the Professor of Anatomy said, no, go back and finish medicine, and then go and do brain research. So that's what I did. In fact, when I graduated, I spent some months doing neurosurgery, because either going to be neurosurgery or brain research. Fascinating time in neurosurgery, wonderful work these neurosurgeons do. But I suddenly realised, this was back in 1971, and that in fact there was so much more we needed to learn about the human brain. So I went back and I started the research career, did a PhD at Auckland here, and then went to the United States and spent 3.5 years in the United States and San Francisco, then at Harvard and MIT, and came back to Auckland as a young senior lecturer and worked on the rat brain, creating my little lab. Great. The basal ganglia and Huntington's disease, you see. And a colleague of mine, a senior colleague, the Professor of Genetics, came to see me, Professor Arthur Veal, and I was actually taught by his father at Newfoundland Boys High School, and then taught by him as a medical student all about genetics. And he said, Richard, you're working on this basal ganglia, all these families in New Zealand who have Huntington's disease, 400 families, he said. And he says it's terrible because this is a dominant gene, but we can't test for it. We only found the gene, you see, much later in 1993. What the family want to know is when mum and dad die, would you look at the brain for them, see whether or not they really do have this terrible disease? Because they need to know, they want to know. And the pathology, you see, for Huntington's is absolutely characteristic. I saw it before, showed it to you before. There it is there. It's a characteristic pathology. He said, would you look at the brains for the families? I said, of course. And I wasn't to know, but that single step was to change my life forever. Because Arthur would arrive every few months, 3 or 4 months, and he'd have the brain fixed in formalin from a family, either in Auckland or Hokitika or Picton or Invercargill, and he was given the brain to us to look at for the family. And we looked, I teamed up with a neuropathologist, Dr. Bessinick, and we would spend several months taking sections and looking at the basal ganglia and finally come to a very clear conclusion, yes or no, they had this disease. And we'd call up the families, write them a letter and do a report to them. And we'd ring them up and just tell them what the results were. For virtually all cases it was yes, occasionally it was no. So imagine the enormous relief to do that. But you know what was the most special thing? They said, well, would you keep the brain of our mum and dad? And would you start doing research on it to find out why these cells are dying to give hope for our children? Well, you have to say yes, right? And so we were given permission from the family, from whānau, to work on their most precious gift of science you could ever give, the human brain. And that was the beginning. In 1981, we accepted the very first brain for research, and that was the beginning, Rich, of our human brain bank. We didn't know we were actually putting together and developing a human brain bank then. And so we'd received brains from all over New Zealand, you see. And we found after looking at the brain, sometimes we needed more information from the families because there were complex things going on which nothing was written in the textbooks. So we would go back and get more and more information from the families. So you see, to date we've got tissue from about 1,000 brains in our human brain bank. Because families work with us closely, we get the brains relatively soon after death because they know that's really important for doing gene studies and so on. But most importantly, you see, we keep in contact with every one of our families forever. They become partners. We are the custodians of the brain. We look after it. And they can come in, and families come in and visit the brain bank, and just to know where their loved one is. And some of our Māori families, they will actually say karakia over the freezer to remember their loved one and what they're doing to help their children. And that moves us more to do research than anything in the world because we're having an impact. And so because of that, you see, we've got this unique partnership with families and also with the clinicians because we often need all the details of their clinical records, which the families say, yes, do that, go and contact our doctor and so on. So we've built up this partnership between families in the community, people in the community with brain disease, clinicians, and of course with researchers. And so the brain bank today, well, in 1994 was when the Neurological Foundation came on board and said, we would like to support this brain bank because we were well established then. And we've expanded over the years to cover all these different diseases and working not only with the Neurological Foundation, who gives us marvellous support, and they've just funded us for another 5 years and increased funding for now more staff, and we are supported by the different organisations now. You see, you'd never know where life's going to lead you and where a story develops and where that's going to lead you, what it's going to enable you to do science, which is better than anyone else in the world. Because we have this precious tissue in our human brain bank, because we know all the history, there's no other brain bank in the world that has this sort of brain bank. It stores brain tissue, but it doesn't have the family connections, doesn't have the detailed family history, and all the details which we have collected through the family contact, the clinical contact. So we have the track record, you see, of all this precious brain tissue. And so over the years, we have, with families' consent, we have worked with groups overseas, virtually 25 different groups, some in the UK, these are leading groups on doing research in genetics in the UK, and others in Europe, and others in the United States, in Boston and so on. I just put those up to show you that through this tissue, because we couldn't do everything in Auckland, and other groups overseas, because of their funding situation, the better techniques are developed and all the rest of it, we can't do everything here, they suddenly provided us with an opportunity to extend our research horizons. And so we asked the family, are you happy if we send a little bit of mum's brain to MIT or to Harvard University in Boston so they can do genetic studies, or to Wales or whatever? In every case, they enthusiastically say yes. And they're so proud of the fact that their mum's brain is going to actually advance knowledge on a worldwide basis and help us to collaborate with all these different groups. And one family said, you know, it's like Mum's getting more travel and death than what she had in life. And another one said, you know, our dad lives on forever, really, helping to look after and advance science for our children. What's interesting is that unconsciously we can collaborate with all these different groups because we've got something unique in New Zealand. It's because of our connections to the families. And we can collaborate with groups easier than what groups at MIT can collaborate with the people next door. You see, that it's very competitive in the United States and in Europe. So people are very suspicious about collaborating with people in the same institution, but they'll collaborate with New Zealanders. And they will work, so they extend our horizons in the most precious way. And it's a bit like, you know, the very sad events we've seen from last Friday, right, with the huge impact of this terrorism. And yet, in a way, New Zealanders come together in the most special way. And this happens in so many walks of life, that New Zealanders are so sympathetic to the needs of others. They will volunteer, they will help in research in any way possible, and that helps us to do very special things. So what I'm telling you about, although I'm the person doing the telling, there's a team behind me. Some of our team are here today, and some of our people running our human brain bank are here, standing up the back and so on. And we have, you see, a marvellous collection of scientists in the University of Auckland, a marvellous collection of neurologists and neurosurgeons and neuroradiologists, and of course the wonderful families that all work together. And so we have this community which, if someone had said to me, you've got a dream, before you start research, write the wildest dream you would like to do to achieve in your research, I could not have written a dream which involved partnerships with patients and families, clinicians in the hospitals, and neuroscience across the university. But that's what we have created, and in the most interesting way, and we've brought the groups in the university across, and we've formed a virtual umbrella organisation. We call it the Centre for Brain Research, but we could also call it the All Blacks of Brain Research, you know, and all the groups, research groups who are doing brain research in the university, they just want to belong to this club, to this group, because we promote collaboration and provide an environment where they can work together, using our human tissue, using animal studies and all sorts of studies. But together, you see, you can achieve more than what you can ever achieve singly as a single group. And so, it's the Centre for Brain Research, the researchers, the clinicians in the hospital, and the community organisation. We have 84 research groups across the university. It's about 450 people. All the community, virtually 30-odd community organisations, and they've all got their stalls out there today telling you about themselves, you see. And of course, the neurologists, neurosurgeons, neuroradiologists, the people in the hospital are absolutely critical. So what's fascinating is that this type of team ethos enables us to do things which are really change the world of brain research. I'm going to give you 3 quick examples because I promised I would keep the time already over. So, first example. When we were doing our Huntington studies, we found in the early 2000s, we found that right along the edge of the ventricle here, Huntington's brain, where there was massive cell death here, we found that there was a layer of cells which were increased, markedly increased. And to cut a long story short, what we were seeing was new brain cell formation, which no one had ever told us about. They said the human brain, once it's mature, can never make new brain cells. We knew in the rat brain that there were always adult stem cells along this margin of the ventricle, just underneath what we call the ependema, and those are really adult stem cells. In the rat brain, we'd seen and been recognised since the 1960s, these cells multiply and make new brain cells, you see. But we're told this doesn't happen in humans. And when we saw that, we thought, wow. I talked to my colleague, Mike Dragon. I said, Mike, I think these are new brain cells. He was a bit sceptical. We applied different antibodies and we looked, And we identified and showed that this in the normal brain is this where the adult stem cells lie. And this was what we found in the Huntington's brain. And we did multiple stains and showed that, in fact, a proportion of those were brand new neurons, thinking brain cells. Some were glial cells, but they were new brain cells, you see. And this is substantial. This is not any little Mickey Mouse increase by double. This is multifold. And so we knew that in the rat brain, this had been recognized in the 1960s, and that they formed new brain cells ran on the motorway, you see, in Auckland here and Wellington. And when they got down to the bottom here, these new brain cells would leave and mature and replace cells in the olfactory bulb or in other areas. So this is a well-established pathway known in animals, but not in the human. So we knew we had to find this pathway in order to make sure and publish the results. And so we started hunting. People like Miles Curtis and Monica Cam and others, PhD students over about 5 years, we went hunting and we ultimately found it. And this is, what you've seen here in 2 slides is about 8 years' work. So what was interesting, that this motorway didn't go directly from Auckland to Wellington, but went around Mount Taranaki, you see. And when we looked at it, we thought, well, we can understand that after lots of thinking, because in the human brain you have this massive enlargement of the cerebral cortex, and this distorts the pathway. But the pathway is there. And suddenly we had this new finding. We tried to get it published. We sent it off to Nature. There's 2 top science journals, Nature in UK and Science in the USA. We sent it to Nature, and it went out to referee to top scientists in the field who had been looking for this pathway, actually. And when they came back, they didn't find the pathway, and of course they were very critical, and we got trashed and said that unless you can actually show the cells actually migrating, we won't accept this. So it was declined. So we then did more work on it and sent it off to Science, the other top journal, and went off to a different group of referees, and it was accepted, and it got on the front cover. And that was incredible. So suddenly, you see, we had shown that the human brain can make new brain cells, and that means it's a plastic brain. Our brain is forever changing. Every second, since the beginning of this lecture, your brain has changed. You've learnt new things, so your brain must have changed. May have all new, your dendrites can become more complicated, your new, maybe connections are formed or so on, and ultimately there may be new brain cells. So it's continuously changing. And that is incredible now that we know that, because there's hope. We know from animal studies, if you exercise and stimulate them by putting rats into a cage where they've got lots of things to do, or put them in a running maze, and you can measure the new brain formation in rats, then it'll increase by 40%. So, translate to humans, that means those same activities, expanding your mind, being in a stimulating environment, doing exercise, is going to enhance your brain. We know that from rat studies, doing too much exercise, overstress in the brain, can actually result in a reduction. So it's like a lot of things. There's always balances. We still got to find out to what extent this really applies in the human brain, but it gives us a completely new horizon to look at how we can help the human brain fight brain diseases. And I like to think that creative thinking makes new brain cells. So, use it or lose it is an absolute paradigm which is critical. Never, ever give up. Keep thinking until they screw the lid on, all right? Anyway, so a second area of research was, this was a line which was developed by Professor Russell Snell, a New Zealand geneticist who's working in Wales and also at Harvard, who'd been involved with finding the Huntington's gene. He came back to New Zealand and he said, this is 1998, he said, we should study the sheep brain and see if we can put the human gene into a sheep and see if we can then use that as a model to actually find out how we could turn that gene down or turn it off. And this is probably 20 years of work. 1998 he arrived, and so in the early 2000s with support from the Freemasons, this was a wild idea, you see, of taking the complicated human gene from the group in Boston. It was just it occurs at the short arm of chromosome 4, and you can take that gene and you can actually put it into sheep. This is done in Australia in a special research institute which does transgenesis in sheep. And I won't go into all the details here. It's pretty complicated stuff, but it's pretty exciting stuff. And so you can insert the Huntington's gene, in this case it's 73 repeats, and we made several lines of sheep. One of those lines was actually an ideal line, this one here, which we happen to call Kiwi. All the other lines we gave... All the other lines we gave different names, like Aussie. Actually, Aussie turned out to be a runt. For our Wales connections and so on. But so the Kiwi line is what we have established, and it is used and been utilised by groups overseas as well as us, specifically to see whether or not we can turn down this gene now. And there's clinical trials starting this year in New Zealand. We're involved with that, led by Dr. Richard Roxburgh and others, and we are providing patients in Auckland with Huntington's disease and New Zealand with Huntington's disease, together with groups overseas, a big international study where they're using a special chemical they call them antisense oligonucleotides, which you inject into the cerebrospinal fluid through a lumbar puncture at the back here, and the initial studies look very promising, and they're now doing a trial to see if we can, by injecting this special chemical which would seal and stick to that messenger RNA and stop it making the bad protein which causes brain cells to die in Huntington's disease. We will have an idea in about 5 years' time whether or not this is going to work, but this is the first hope on the horizon, going right back to the early days when we started talking to Huntington's patients, where we can say, you know, research is working for you, and we can give you hope now. And it's marvellous, because whatever happens with this trial will be important for all other brain diseases where genes play a role. For me, that's music to your ears, you see. So thank you, families, for the way in which you provided us in our early research years with knowledge which got us onto this big research bandwagon on the world's scene. Thirdly, the final one I just want to tell you about is, because of our relationship with neurologists and neurosurgeons, we get access to look at patients who have brain disease, but also with the neurosurgeons, they take brain tissue out of, when they do an operation for people who've got a brain tumour or got some other type of brain disease which surgery can help. And so over the years, we've developed a partnership where we take tissue, which is for the patients and the family's consent, which has been resected in operation, and Mike Dragonoff, this is his team's work, Joe Montgomery and others, and they can take that tissue straight off the operating table, bring it from the hospital straight across the road. We then digest and dice up that tissue and make a sort of a suspension of brain cells in a dish in the lab, in a special culture dish. It's like having a disease in a dish, you see. They're individual cells dispersed. We're not making a brain. We've got cells keeping them alive, which are characteristic of a particular disease, whether it be a medulloblastoma, a tumour, or whatever. And then you do analysis in the lab, and you can see whether, and you can trial drugs which may help stop those tumour cells from dividing or so on. And so if you take from the, you know, this is cells just being cultured, which is from a normal brain, a person who died without a neurological disease, and compare it with the brain of a person who had epilepsy, for instance. You can see this marked differences here. The cells show differences which you can use to develop therapies. This is human brain cells. And so this is a real complicated slide, just to show you that there are many types of human brain cells, and there's types of microglial cells, astrocytes, and so on. And we can now grow any of those cells. We're one of the few labs in the world that can do that because of the relationship we have with our clinicians and with patients and families. And the one which we've been able to grow and keep alive most recently are actually the neurons, and we're just in the final stage of publishing this information. This is all the detailed information which tell you that is in fact a neuron, a thinking brain cell, if you like. And so we can actually study human brain diseases in the lab, and that has got to be incredible. I would never have dreamt that. So this has all come from teamwork. Teamwork which researchers working together across the university, 450 of them, doctors, neurosurgeons, neurologists, neuroradiologists, psychiatrists working in the hospital, working with us, and most of all, community organisations and families who are really the focus of why we're doing this research. And you see, when you have this incredible opportunity, you want to make new platforms. You want to be able to, in the first case, we wanted to have a human brain bank, and it's grown slowly up since 1981, and now the 25 years you've just been by Rich, that the Neurological Foundation have been supporting us for 25 years. And I think we've got to say thank you to them for that. Yeah. And coming after that have been other platforms. You see, the biobank where we keep these brain cell cultures going. Hugh Green Group. Hugh Green was an engineer. He died some years ago, but their trust fund is supporting this whole program of growing human brain cells. Over $3 million I've put into this over the last 3 years. It's incredible, and that's the platform we're going to find new drugs to fight brain disease. And so we go on. This is a platform to support our animal studies, spinal cord injury unit, the Catwalk Trust support that, and so on. We have clinics where we look at patients with actual diseases. There's a stroke recovery clinic. Cathy Stinear, Professor Cathy Stinear lectured this morning, and she would have told you about some of the marvels that we can do in the stroke recovery clinic because we can do research on people with the disease while they're alive. The Dementia Prevention Research Clinic, that's the Brain Research New Zealand, the core, which we're doing that with. The Wolf Fisher Trust has been critical in that support, and Motor Neurone Disease Research Clinic we're setting up, and also we're just establishing a genetic brain disease clinic under Dr. Richard Roxburgh, and so on. We've got a neurosurgery research unit. All of these are units of people brought together who are being funded by philanthropy, by groups out in the community, Freemasons, Sir Graham Douglas and others over the years who have made our research dreamland come true, really. Aotearoa Foundation in the United States, the Hudson Families for our postdoc research fellows in Huntington's disease, the Sir David Levine Trust, who gave us this money for a chair in brain research just before Christmas last year, the greatest Christmas present one could ever dream for. So you see, it's all about partnerships and brain research and giving hope to people. That's what it's all about. And so teams make dreams come true, and science is all about people, and that's what we're about in the Centre for Brain Research. Thank you very much. Use all your time.
So thank you very much, everybody. We may capture questions afterwards because we've sort of run out of time, but I'm sure if you want to come and ask Richard, he'll be around for the next 5 or 10 minutes just to cover your questions. Thank you very much for coming.
Hello, my name is Debbie Young and I'm the co-chair of the Brain Day Organising Committee. It gives me great pleasure this afternoon to welcome you to the last of our public lectures given by Professor Debbie Hay. Debbie Hay is a current James Cook Research Fellow and she's from the School of Biological Sciences. And so today what she's going to tell you about is something about her research, which is focused on migraines and headaches. Debbie.
Thank you very much, Debbie. Now, can everyone hear me adequately at the back there? All right, fantastic. There's no point me doing this if you can't hear. Bit louder? Yep. How's that? Is that better? Fantastic, thank you. So it gives me really great pleasure to be here this afternoon. I'm really pleased that my flight was on time this morning. I came in from Shanghai, where I was presenting at an exciting conference there. And so I really hope my presentation goes smoothly, but if something does go wrong, please forgive me. I shall blame it on a little bit of jet lag. So migraines and headaches then. Why am I here talking to you about this today? Well, migraine affects 1 in 5 New Zealand women. This means that out of this audience, there are bound to be people here who either are directly affected by this or know someone who is affected by this. Migraine is a really important condition, and I'm going to talk to you about a number of different aspects relating to this today. Let's start with a few facts. So, migraine is more common than diabetes, epilepsy, and asthma combined. 1 in 7 people overall suffer from migraine, and that's 1 billion globally. However, less than half of those with migraine actually see a doctor about it. Now, why that is not completely clear. Maybe they've given up going to see their doctor because they feel they can't be helped, or maybe they just sort of live through it and think there's nothing that can be done. Probably lots of different underlying reasons. For those who do seek help, finding a doctor, a headache doctor, is incredibly difficult because there are very few hours committed to headache training in medical school. In the US, where there are specialist headache practitioners, there are very few of them, and this makes it really difficult for people to get the right treatment that they actually need. Importantly, this is a really costly condition to the economy. It costs the individual hugely in their day-to-day life, but it also costs the economy enormously because people will often have difficulty attending work, for example. So I'm going to go through these different aspects today. So I'm going to explain to you what migraine is. If you don't know, this is going to help you understand this condition. I'll talk about migraine treatment, a little bit of history, where we are now and where the future is heading. And in particular, I'm going to talk about a class of molecules, a new class of molecules that are really offering hope to many sufferers for the first time. But also, this is not the end. We have some new hope, but there's an awful lot more that we don't know and a lot more that we can do. And that relates in part to our research going on here at the University of Auckland. So let's start with, what is migraine? This quote here, I think, does sum this up quite nicely. Chronic migraine, grave, disabling, and receiving little attention. Chronic migraine is a disease of great detrimental influence on a patient's life. I like that quote. I think it sums it up. But if we look at this a little bit more closely, we'll start with what migraine is not. Migraine is not the same as a headache. There is a lot more to migraine. When we think about migraine, yes, headache, that is something that definitely springs to mind, but that is not the only aspect. It's classified as a disabling primary headache disorder, so that's different to a secondary headache disorder, such as a hangover, for example. So this is a disabling primary headache disorder, and what's really fascinating about migraine is it's so diverse. Every single person will experience migraine a little bit differently. And that word experience is really important here. Migraine is an experience, and it's really unique. I haven't listed here the large number of different subtypes of migraine classification. I'm happy to talk to you more about that if you'd like. So we'll keep it relatively simple and broad. It does frequently include severe headache, and that's usually on one side of the head principally, so a unilateral, one-sided throbbing headache. And you will usually have it on the same side every time. But actually, not every migraine sufferer gets headache. And often in children, migraine doesn't involve headache at all, at least not to start with. And that makes it really difficult to diagnose. Migraineurs will frequently be super sensitive to their environment, not necessarily all the time, but when a migraine is coming on, they will usually start to feel much more sensitive to their environment. Light will just start to be a little bit more problematic. Light can sometimes even cause pain. There'll be hypersensitivity to sound, smell, touch. And touch is something we don't tend to think about so much, but actually you will often be hypersensitive to sensation. And there will often be gastrointestinal disturbances. Nausea and vomiting are very frequent. Now, many people will have what's known as acute migraines, so they might have 1 or 2 migraines a month, for example. But what can happen over time is that this can become chronic migraine. So acute or episodic migraine can chronify, as it's called, and become chronic migraine. And this means that approximately half of the month you have a headache. And you can imagine the impact of that on an individual. This does often start in childhood, affects people through much of their adult life, and it does tend to disappear with aging. A benefit, I have been told, of getting old. But it's really interesting because migraine just sometimes comes and goes. You'll talk to people and they say, yes, I used to suffer from migraine, and then just one day it went away. This is what makes it a really challenging condition to study. Now, migraine aura I haven't mentioned so far, but this is a series of symptoms that not everybody gets, but many people do get, and these are sorts of visual disturbances, for example. And I think a really nice way of illustrating this is with this image here. So it's said that Van Gogh actually was a migraine sufferer. And migraine was considered back then to be a mild insanity. And that's because people didn't understand it. And it is really thought that Van Gogh's migraine auras inspired much of his work. And you'll find that many migraine sufferers are incredibly creative. Is this because they experience the world slightly differently? Another famous migraine sufferer was Lewis Carroll. Again, an example where perhaps his incredible work, such as this, Alice's Adventures in Wonderland, were in fact inspired by his experiences and his aura. More recently, migraine art has become a really good way of helping people to explain their symptoms. If you do not suffer from migraine, it's incredibly difficult to get across to someone else. If you do suffer, if you don't suffer, having that conversation is really hard. And migraine art is a really nice way of doing that. And there's some really great work that if you look in this book or on the Migraine Action site, you can see how people are explaining their migraines. And recently, there's been an initiative in the last few years called Migraine Moments. And this is an initiative worldwide where people record their own videos of their own experiences. And it's a really interesting way of helping to understand and have a conversation about migraine. And so, to illustrate how migraine is much more than a bad headache, I'm going to try and play you this short clip.
CBS News' Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy debatation tonight. We had a very daring But let's go to Terry's and look for the head of the pit.
So you could understand that, of course, perfectly. What was happening was there, and people were really concerned about this at the time, they thought that news reporter was having a stroke on air because her speech was so disturbed. In fact, she was having a migraine. She couldn't understand what had happened then, and it was quite shocking for a lot of people who watched that video. But this just shows you how migraine can affect an individual during an acute attack. And so just to reinforce to you, migraine is much more than a bad headache. It is, in fact, a complex neurological disorder. And so what triggers a migraine attack? Those of you who suffer from migraine, or perhaps family members of migraineurs, will know that you spend a lot of your time trying to avoid triggers. You live in fear of certain things that you know will cause a migraine. That can be stress, it can be the menstrual cycle in women, it can be changes in weather even. These can all bring on a migraine attack in different individuals. Some common migraine triggers are shown here: bright light, caffeine, red wine, and perfume, so very strong smells. And in fact, I attend a number of different headache conferences around the world, and on their rules, do not wear strong perfume to the conference, because this is not very good for your colleagues in the audience if they are migraine sufferers. So we know that a number of different things like this can trigger an attack, but what happens in the brain with an attack? This is the really simple version. Triggers cause activation of the so-called trigeminovascular system. So we all have a nerve called the trigeminal nerve, or the fifth cranial nerve, and this is the major nerve in the face and head that is important for sensation and for pain. We know that these triggers activate that system. We also know that there are lots of different parts of the brain within the central nervous system and outside the brain in the peripheral nervous system that are involved in a migraine attack. And in fact, it's incredibly complex. Now, this is a complex diagram, but I'm just going to point out three components of this that are important to understand, which is that a migraine does involve blood vessels relaxing, vasodilation, vasoconstriction. There are definitely effects on blood vessels. We also know that there is release of molecules that cause inflammation. And we know that there is pain transmission. And we also know from some really interesting neuroimaging studies, so this is where an individual has a special type of MRI done, and their migraine is provoked in the machine. That then allows you to see which different parts of the brain are being activated or having decreased activity during a migraine attack. And you don't need to take on board all of the details of this slide, aside to say that if you compare what happens in a migraine sufferer's brain compared to a non-sufferer's brain, there are all sorts of different areas that light up as more active or less active. And of course, this is very likely to explain all the different symptoms that occur during a migraine attack. But really, that's kind of all we know. I mean, migraine's been around for a very long time. It's been recognized for hundreds, if not thousands of years. But it's still a neurological mystery. Where exactly in the brain does migraine start? Every single headache conference I attend, this is a topic that is debated. No one can agree yet. Why do some people have aura, and why do some people not have aura? What of those different pathways that are happening in the brain, all of those different places that Richard explained to you, which of those pathways are causing aura? What causes the nausea and vomiting? How is that linked to the brain? And why is the hypersensitivity to smell, sound, and light? And why is migraine more common in women than men? We have some answers, we have a lot of speculation, And we really are not at the bottom of this yet. And I think in part it's because this is a complex condition. It's hard to diagnose, it's hard to understand, but with research we are making progress. And so let's look a little bit now at migraine treatment. So firstly, as I said before, migraine has been around for a long time. And these are the types of treatments that have been used to try and relieve migraine. This is my favourite. I don't know what your favourite here is, but I mean, surely extensive controlled trials were done to show that binding a dead mole on the head was effective for migraine. I mean, where did these things come from? I don't know. Leeches. Now, that's a really common medieval treatment for pretty much everything. A recent article in the Daily Mail UK suggested that some people are still trying to use leeches to relieve migraine. Maybe there's truth in it. We don't understand the science. But, you know, people have tried a lot of things and are still trying a lot of things. One thing that was particularly popular at one stage was the hydroelectric bath, which apparently did have some success. I mean, that sounds like an absolute health and safety nightmare. But I mean, this was used. But in terms of where we are sort of now, in terms of migraine treatment, things have improved, and there was a huge breakthrough in 1991 with the approval of the first migraine-specific treatment. These are called the triptans, and a number of you will have heard of triptan drugs. Their origins actually come from contaminated grain. So there is a particular fungus that contaminates grain, or used to contaminate grain, called ergot of rye. And this, in the Middle Ages, caused something called St. Anthony's fire, which was severe pain due to blood vessels closing up. But what people started to understand was that maybe this effect could be used beneficially. And so they would start to make extracts of this and tinctures for medicinal purposes. And it was discovered that in some people this actually did help their migraine. And through a lot of medicinal chemistry, they found molecules or designed molecules based on the compounds that came out of this, creating this first triptan drug. So a really nice way of showing how nature has helped us to identify these drugs for migraine. And so what does modern medicinal migraine treatment look like? Well, there are two things. You have acute medications. So these are drugs that you are told to take when you feel a migraine coming on. And these are to help blunt the migraine, stop it in its tracks. And so people will usually be told to take regular painkillers like paracetamol, or they'll be prescribed, or in combination, the triptan drugs that I mentioned to you, like Imigran or Risomelt. And these are all based on the same type of mechanism. And these are effective for quite a number of patients, and these have been a tremendous advance. But they actually also can't be used by huge numbers of people. If you have any kind of problem in your cardiovascular system, you're not allowed to take these drugs because they have side effects. And so whilst they are good for some people, they're not good for everyone. There are also some classes of preventative drugs. And these are really interesting because these were actually never designed for migraine. They've come from other therapeutic areas. So the current drugs for migraine prevention are actually depression drugs, high blood pressure drugs, and epilepsy drugs. And it was found that they did help some patients with migraine, and so they are approved for use and recommended for use for migraine. And that's why, again, a number of you here may take one or more of these. And taken every day, they can help some patients. but they certainly don't help everyone, and they do have side effects that really mean that people don't want to take them. If you look at the number of people who start taking these preventative medicines, they seem to manage to keep taking them often for about 3 months, and then they stop taking them. Why? Because they don't work or they've got side effects. If they work for you, fantastic. If they don't, I'm sorry to hear that, but what I am here to tell you about are some new things coming along. So there are some newer options which are not medicinal, but which are really interesting in the way they work. And so you have this type of nerve stimulation device. This is one of these types of things, and you wear it on your forehead, not something you want to go out for dinner wearing, obviously, but something that, you know, in the privacy of your own home, used for the right amount of time as prescribed, can help your migraine. And there's also Botox. You'd be more familiar with that from smoothing your creases and what everyone in Hollywood uses, but actually, Botox has been found to be really useful in many migraine patients. When injected into specific sites in the forehead, for example, this is thought to effectively stop the nerves from sending pain signals. And so this does work for many people. And you can get Botox treatment for migraine in New Zealand, but unfortunately this is not Pharmac funded at the present time, although they are campaigning for this. So there are some options, but modern medicinal migraine treatment is still inadequate, and large numbers of patients do not have effective treatment. Maybe they take a cocktail of things that can take the edge off or diminish attacks, but migraine is not abolished for a large number of people. So what do patients want from future migraine medicines? And if you're a migraine sufferer in the audience and you have not got an effective treatment, I'd like to know what you would like. What is going to work for you? But I believe they need to be effective, they need to be safe, they need to have few side effects. Ideally, they will prevent migraine, and designed specifically for migraine on the basis that they affect migraine-specific mechanisms and not other things. And so I'm going to move on to the next part here, which is where we're going to talk about how some really interesting developments are now offering hope to sufferers. And so I'm really pleased to be able to announce to you that some new drugs have been approved for use in humans for preventing migraine. The first of these is this one here, Orenumab, with the trade name Imavig. This was approved by the US Food and Drug Administration and the European Regulatory Authority in mid-2018. This is the first drug actually designed to prevent migraine based on underlying migraine mechanisms. It was the first drug in its class for its target, and I'll tell you about a couple of others later that are also now approved. And it targets a particular molecule called CGRP, calcitonin gene-related peptide. And I'll explain to you what that is. So we all have CGRP. Every one of us has this molecule called CGRP. It's a so-called neuropeptide. It's found in our nerves, and it modulates the activity of target cells. So it's made up of a sequence of amino acids. These are protein building blocks, and the unique way in which these are strung together creates unique biological molecules. So this is CGRP here. It's shown as just a little red dot here. It's packaged into nerve cells. And when this nerve cell is activated, CGRP is released, and it acts on a special target site known as the receptor, leading to signaling within a cell. Now, this is an important concept, and so to make sure that you're all familiar with this, I'm just going to switch over to the document camera and just reinforce this point, because actually understanding what a CGRP receptor is important for understanding other aspects of my talk. So is that up there? Everyone can see it? Good? All right. So this is where you see my potentially very bad left-handed writing, but Richard encouraged me that being left-handed is a good thing. So what I've drawn here is a target cell. So that's the membrane of a target cell. This is outside the cell, this is inside the cell. And on the surface of that cell, you'll find a protein called the CGRP receptor. And this is the specific protein that CGRP, once it's released from that nerve cell, there's CGRP, it will bind to that receptor rather like putting a key into a lock. And what happens is that will become activated. So there's the receptor again. Now CGRP has bound to its receptor like a key slitting into a lock, and that has now become activated. So that's now the active CGRP receptor. And that is a critical step, because what can happen now is that there is a transmission event. A message from the outside of the cell to the inside of the cell has occurred, causing changes in chemical messengers inside the cell. And that causes the pain. Now, what's quite important about this is that CGRP only recognizes a specific target. So the key fits into this lock and not other locks necessarily, although I'll come back to that later, and that's why this is important. And it causes chemical changes in the cell that transmit pain. And this type of mechanism is really important for how all of our hormones work and for how about 30% of all medicines work. They work by having a specific molecule and a specific receptor creating specific effects. And so that's really what this summary diagram here is showing. And so we know we all have CGRP, and this is how it works. And we know that it modulates the activity of nerves that control pain. It also has other effects, like it's able to relax blood vessels, and knowing that blood vessels are involved in migraine shows this link, but its true role is still not known. But we do know that migraine sufferers have much higher levels of CGRP in their blood. So during a migraine attack, if we compare the amount of CGRP here outside of an attack and during an attack, you can see this is much higher. About 4 times more CGRP is released into the blood during a migraine attack. And this has been done by testing volunteers, testing blood samples from human volunteers outside and during a migraine. And so that was really important evidence that CGRP was indeed involved in migraine. But there's some more really compelling data. And that is that CGRP directly triggers migraine. And this experiment has been done in experimental human models of migraine. And this is where a migraine patient will come into a lab and they will be given an infusion into the arm of the CGRP peptide. Their blood vessels can be monitored, and they'll also then provide a score of how much their headache has come on. And this is fantastic work done at the Danish Headache Centre in Copenhagen, and I had the privilege of visiting some fantastic young scientists there late last year who are doing a number of studies where they infuse different triggers, different molecules into migraine sufferers who happily volunteer for this, even though it will give them a migraine potentially, because it helps us discover new migraine targets. So using this type of experimental setup, if you give CGRP to a non-sufferer, they will only get a very mild headache. But if you give CGRP to a migraine sufferer, they will get migraine. 80% of people will get a migraine. So that shows that migraine sufferers are sensitized to CGRP. It seems to work more in people with migraine. And so this illustrates this. In a migraine sufferer, there is more CGRP that activates more CGRP receptors, leading to more pain signals. So it's as if the whole system is dialed up in a migraine sufferer. But what's really important, and that's where these new drugs come into play, is that we can block this. We can stop these effects. We can either take a molecule like this one here, plug it into the active site of that receptor, that stops that pain signaling, and that can stop a migraine in its tracks. There are also some antibody types of drugs which are designed to either bind to this receptor and stop it working, or to mop up the CGRP, the excess CGRP in the bloodstream. And all of these different mechanisms have been proven in clinical trials to reduce migraine in migraine sufferers. And what there has been is huge pharmaceutical industry excitement in this worldwide. They've been working for decades on this mechanism and racing to the finish line. As I indicated, Amgen won this race with Erenumab, but there are lots of other molecules in development or now approved. So the first ones were approved in late 2018, and more are expected this year. And so right now, what has been approved are these three. You have Aimovig, Ajovy, and Emgality. These all work in similar ways to stop CGRP in its tracks. Now, at the moment, these are devices rather like an insulin pen, which you have a small injection once a month or 4 times a year. And this can help many patients. But of course, there is a big con here. They are expensive. So the price of these in the US is nearly $7,000 per year. And of course, the critical question is, what does this mean in New Zealand? Who can access these and how much do they cost? Now, I spoke to a neurologist colleague recently because I wanted to make sure I had the update information to tell you. And she said that there should be some availability in New Zealand within months, but for now, this will not be Pharmac funded. However, an application to Pharmac should be made later in 2019. Now, we can't make any promises. We can just hope and campaign to make these available through Pharmac. And so this shows here a summary of all the different clinical trials. So it's a bit of a complex slide, but what we're looking at are those small molecule antagonist drugs on the left and the antibody drugs on the right. And the important color is the blue bar. And this shows the number of patients or the percentage of patients who have been effectively treated with that drug. And what you'll see is that none of these go to 100%. This is actually 50 here. Overall, only about 50% of patients respond to treatment. So they are fantastic, they are working for people, but they're not working for everyone. And so there are really important questions here, such as whether we can do better. And so just for the last few minutes, I'm going to highlight how many questions remain unanswered and highlight just a little bit of some of our work in this area. So the CGRP-directed drugs so far, they do work, but they don't work for everyone. And this is only the beginning. Many questions remain. We don't know exactly how they work. We don't know whether they could be used for other conditions. Now, I haven't talked about this today, but there's another condition, for example, cluster headache, This is much rarer than migraine, but it's also known as suicide headache. This is more common in men, and that name gives you a clue as to how debilitating this is. It comes on in clusters of attacks which are very severe, and then they go away for a while. There are not very many effective treatments for this. So are these new drugs useful for that? There are ongoing clinical trials which are showing promise. Why do some patients respond and others don't? That 50% that I said is the average across those clinical trials. If you actually look in detail at those clinical trials, you'll see that there are some patients who just aren't responding at all to these drugs, and others who have been classified as super responders. And these are people who, since their first or second dose, have never had a migraine again. Imagine a chronic migraineur with 15 or more headache days per month who now no longer has migraine. That's incredibly significant, but we don't understand why those patients are responding so well. We don't know whether there will be any long-term side effects. CGRP is a natural molecule that we all have. If we block it forever, is that a problem? So far, the safety data looks great, but we just don't know. And can we make better drugs that are more cost-effective than these antibodies and available to more migraine sufferers? And are there any other targets like CGRP? If not everyone is responding to a CGRP blocker, does that mean there's other things out there that we haven't yet discovered? Well, actually, there is something else which we have discovered through a similar type of human study. It's another horrible acronym. It's called PACAP, and I won't go through the name. But that also can trigger migraine in migraine sufferers. And there are companies who are also developing molecules to try and block that. We're trying to figure out whether if we use both together, will that be even better? And so in my lab here in New Zealand, we're doing world-leading and world-challenging molecular pharmacological studies on CGRP receptors in the context of migraine to help find those answers. Now, I say world-challenging because this is actually quite important. I went through that scheme before where I said that you have a lock and you have a key. And there is the key, CGRP, but there's usually only one lock. We've discovered CGRP has two locks, not one. So are we missing half of the story? Is that why maybe we haven't successfully treated everyone yet? Because actually, CGRP is finding another pathway to go down. So that's pretty important. And I've been out there telling the world this, and they are listening. Now, for those who don't know the term pharmacology, this is what we do in my lab, pharmacology. And this is about understanding drugs or medicines. And it's about trying to develop new ones and understand how current ones work. So we have a molecular pharmacology lab. And what we're trying to do is work to understand all of the pieces of this puzzle. So this is what I showed you before, and I've just converted that into a jigsaw puzzle. We have to understand every single piece of this to really understand this system. So we know that these receptors are essential proteins for transmitting messages in cells. We know that around half of all medicines out there act in this kind of way by targeting receptors. And we were asking how many CGRP receptors are there, and I've just told you there's actually two, not one, as was commonly believed. We're trying to find them in the brain using the brain bank that Richard described to you before. That's a fantastic resource for helping us to pinpoint exactly where in the brain these receptors are found. That helps us understand migraine, it helps us treat migraine. And we're also trying to understand the exact molecular blueprint of these receptors. It's shown here as a little blob. Of course, it's not a blob. It's a really complex thing, and we're trying to understand how it works. So I'm just going to show you one little piece of data which is giving us new insights into CGRP receptors. Now, what you've got on the screen here are some cells, like Richard showed you before. And what we've done with these cells is we've added a fluorescent label to the CGRP peptide, and we've added that to the cells. And what happens at the well-known CGRP receptor is it starts to disappear inside the cell, and you're going to find that quite difficult to see, but what you might be able to see occurring over this time course, that you get bright spots appearing inside these cells. And what's happening here is that CGRP is binding to its receptor, and it's being removed from the cell surface to stop it signaling, to stop it transmitting messages. And that's the normal way that these things work. But what we found is that at the second receptor that we've discovered, this behaves really differently. You do exactly the same experiment, you apply the same concentration of this labeled CGRP, and you apply it to the cells. And what happens is it doesn't go inside, it stays on the cell surface, which means that this second receptor might be capable of signaling and transmitting pain messages much more than this one. So maybe we need to be focusing our attentions here. Maybe that's going to help us make better migraine drugs. And this is the work of some really talented young scientists in my lab who are doing fantastic work. And so what I'd just like to close up and do now, to give plenty of time for questions, is just show you some useful resources. For those of you who want to find out more about migraine, there's something really important happening right now, and this is the Migraine World Summit. This is a virtual conference online, which is free for this week. If you register, I'm hoping you should be able to access lots of information from leading world experts in this space. So free and online is the Migraine World Summit right now. I encourage you to have a look at that because you might find some answers that you need. The American Migraine Foundation has some really fantastic resources on its website. It can help you as a patient understand what type of headache you have. If you're caring for a child with migraine, this will give you some helpful suggestions. It's got useful brochures on understanding the new anti-CGRP treatments. There's also a website called cgrpforum.org, and that is also an educational resource for researchers, patients, and clinicians in the CGRP space. And there's also a write-up in the September 2018 issue of North and South around these new CGRP treatments and migraine in general. So if you're interested in this, I encourage you to look at some of these resources. So I'd just like to close by thanking you for your attention. I hope you've learned something new about migraine, and I'd be very happy to answer any questions that you have, either now or at the end in person if you don't want to speak up. So thank you. So we'll just get some microphones to make sure everyone can hear. There was a question there. Yep.
I haven't seen a neurologist yet, but I would get migraine headache every day, but I take medication that pretty quickly gets rid of it. Preventatives, I've tried 2 now through my GP, 1 fairly recently. Second one is, the amitriptyline. I'm having to increase the dose all the time. And so it seems my body sort of gets used to it a bit, waited if that's the word. And so I suppose I'm wondering, I feel like, I'm a nurse, I feel like I would be good to see a neurologist to sort of see if, what is available right now and what are the options for me, because a good GP, but he doesn't have the specialised knowledge. So, all neurologists or most neurologists sort of know about this stuff?
I would definitely encourage you to see a neurologist because they are more specialist than GPs and they will often have more time to speak to you, and I think that's important. There are not a lot of specialist neurologists, but most neurologists will be familiar in this space. Sorry, there's 2 near each other there, yeah. Oh, no, okay, that's all right.
Since we still don't know how exactly some CGRP-related drugs are working, so why are they allowed to use in foreign countries?
So we know that CGRP triggers migraine. We know that people with migraine have more CGRP. And we know that if we give one of these drugs, that can stop migraine happening. So we do know a bit about how they work, and we know that they do work for many people. There are lots of tiny details in that picture, like that jigsaw puzzle, that we don't know. And so that's what I was referring to. We know enough to show they're safe, to show they're effective, but what I'm suggesting is that there is more to learn so that we can make them better in the future.
Is there a relation between concentrations of CGRP and hereditary passing on of migraines?
So there are different forms of migraine, including inherited forms of migraine, and I think there is not a strong link necessarily in those particular forms of migraine to CGRP in particular. But I would have to check the studies specifically, so I'm not sure. Yeah.
Thank you. So you say you know enough to know they're safe. What does that mean? How long have they been taken for?
They've been taken in some patients for now a couple of years. So whilst the drugs have only just been approved by regulatory authorities, there have been ongoing clinical trials in many different countries now for several years. And that data is publicly available. So the most common side effects are an injection site reaction, and that's very common with any kind of injectable drug, that at the site at which you administer it, there will be a rash or something similar. But generally speaking, there don't seem to be other problems. Now, these have gone into thousands of patients, but I guess we just won't know until they're widely out there in the market to know if there will be any other issues. But what you should know is that people are really paying a lot of close attention to this and monitoring it very carefully. And that's the case with any new drug.
So just to clarify, you said 50% of people were receiving benefit. So that's so the number needed to treat with these drugs is 2. So for every 2 people that take them with migraines, 1 will get less pain within 6 months of
The
starting.
50% is an average. It's an average, and you will see some patients are 100% responders, and others are not getting any benefit at all. And it's not clear yet whether there's a genetic basis or anything else as to why that's the case. I think there was a question in the middle here, and then up at the back.
Hi, I'm just wondering, with the research you're talking about with the CRGP, is there anything done with pediatrics around this and the blocking drugs with peds?
There is a lot of commentary going on in the clinical literature around this at the moment. I am not sure whether any specific trials are going on, but it's certainly something that people are thinking about. What's actually happening yet, I'm not sure. But it's certainly an area that there are a lot of conversations among headache researchers going on.
And do you know anything with regards to the use of melatonin in children with...
No, I don't know about that.
All right, okay, thanks.
So up the back there.
Hi, thank you very much. With the CGRP and the trigeminal aspect that you mentioned, is there any CGRP aspects that they've investigated with trigeminal neuralgia?
Yes, that's a really good question. I think there will very likely be some involvement, but it's not been studied very much. But trigeminal neuralgia is another place where it's possible these drugs could be useful. But I'm not sure of the exact studies that are going on that at the moment. There was a question at the back over there. Yes. It's not something I've seen much on at any of the headache meetings I've been attending for the last few years. There's a lot of association between migraine and all sorts of different things, but the linkages are often quite blurry. So in that particular case, I haven't seen anything recently, but that doesn't mean to say that that isn't still a link. It's just not a space I know about. Okay. So right in the middle there, I think. I hope I'm not missing people out.
Hello. Are there any known triggers for a hemiplegic migraine?
Hemiplegic migraine is not something I know a lot about, unfortunately, so I would not like to speculate specifically on that.
Would you suggest a neurologist might help?
Absolutely.
Thank you.
I hope they would be able to. I can't guarantee that, but I would hope.
Thank you.
There's a question down here at the front. Okay, let's go at the back there first, and then you next. Trigger testing. Okay, right. That's a good question. I'm not seeing. So that's trigger with ear piercing.
Triggers? Yeah. Is it triggers? Ear piercings? Triggers? Something like that? Yeah.
Right. No, I'm not aware of that, but maybe others are.
One more question is, I have what we call benign positional vertigo. I've read a bit about it. Is it related to migraines?
I have heard of this, but I would not like to speculate on specifically whether it's related or not. But again, a neurologist would perhaps be a good person to ask.
Okay, thank you.
Okay. Sorry, I can't answer every question. Lady with the blue scarf first, and then yourself.
Thank you very much. My question is related. You're talking about these new drugs that could block the CGRP. How about old drugs like Panadol? Is it kind of similar effect or different principles?
No,
could you just give us a little bit more?
Different principles. And one of the problems is that all the general pain medications are for pain generally, and that isn't exactly the same as head pain. So they kind of work, and they do help some people, and they will take the edge off, and maybe they will abolish it for you. But they will influence pain generally, but not specifically head pain. And they don't seem to involve CGRP. Yeah.
Sometimes migraine is not a straightforward diagnosis. 50% are not responding. Could it be that they are diagnosed as migraine?
That's a really great question. So migraine is underdiagnosed, and it's difficult to diagnose, especially when it doesn't always come with the headache, and when there are so many different diverse symptoms associated with migraine. And people are constantly updating the criteria worldwide to make sure we get better, more adequate diagnoses. So the question was, are those trial results with the 50% average responders related to not good diagnosis? I think in this case the answer is no, because those are done very carefully with headache specialists, and they won't be allowed into the trial unless they have got a very clear diagnosis. But it's a good question. Sorry.
Yeah. Hi. One woman recently posted online that she used a clip between her thumb and her pointer finger. Do you think that would work?
There are many anecdotes online, many anecdotes online, and the leech example was kind of one of these. Maybe there's a basis for it, but you know, as a scientist, I'm driven by robust clinical studies. And the thing with migraine in particular is that you have a very high placebo effect because you really want benefit. And it's remarkable, actually, how if you were to look back at those slides, and I won't flick back, the placebo rate for those who didn't get active drug was very high. And is that because they are now just being cared for better? They are now actually seeing a headache specialist. They are actually thinking carefully about their triggers. And there are many anecdotes, and I think it's something we really don't understand at all. Sometimes there's little harm in trying these things, but always weigh up the harm versus potential benefit for anything like that. So who's been waiting a while? Because I'm a bit lost with, okay, sorry.
That's all right. I just wanted to know, the new treatments that are coming out, would they have the same effectiveness on people with TBI and migraines?
So that's traumatic brain injury and migraine. The research on traumatic brain injury and CGRP, there isn't a lot of it yet. There's some very early studies that may be showing a linkage between CGRP and traumatic brain injury, but it's too early, and I'm not aware that there are specifically trials yet on that. It's something that people are thinking about, like I said with trigeminal neuralgia, but no clear data.
With migraines and brain tumours, should they be seen as symptomatic of each other, or should they be seen as two separate entities?
I would say probably separate entities. Yeah.
You touched on cluster headaches. Are they vastly different from migraine? I think that's more what I suffer from, and I've never heard it called suicide headache before, but I can understand why.
Right, yeah. They are different, but cluster headache is studied even less than migraine is. So if you think back to some of the statistics I had right at the beginning about how common migraine is, okay, if you attend one of the biggest conferences in the world on research in this area and clinical conferences, you might have 1,000 people attending. If you go to one on diabetes, there'll be 20,000 attending. So there is a huge disproportion situation here between how many people this affects and how much research there actually is going on. Cluster headache is a small proportion of that. And so I think that, from my understanding, the mechanisms are distinct, but given that CGRP does appear to be effective, or some of these are effective, maybe there's some commonality there that we've yet to uncover.
Has there ever been any research done into whether migraine is an autoimmune condition?
Not that I'm specifically aware of. Okay. But there is quite a lot going on, and that's not one aspect I'm familiar with. So, yep.
Thanks. I'm wondering, when you go to these conferences, to what extent are people speaking of migraine in the same vein as we do of chronic pain and central sensitization? Because I guess I spend my life educating people there's no such thing as pain transmission, there are no pain pathways, there are no pain signals, get that out of your heads. And then I come to something like this, and people are being told there's pain transmission and pain signals. And I look at migraine and I just think it's pain's an output, and there are lots of inputs, and we found one input here that could work. But I wonder if we'll ever get away from needing to look at the whole picture all the time anyways. You know, like, we're looking for the magic bullet here, but in my experience, 20 years of working with people with chronic pain, there's never been a magic bullet. And so it's good to keep looking at the whole picture.
The picture is, as ever, much more complex, especially than one can put forward in a public lecture such as today. So there are aspects that I have simplified. Are the magic bullets? Rarely. But clearly, as you suggested, we found an input that has resulted in a drug that does work. Now, pain, chronic pain, is different to migraine.
That's probably the question. Like, what is the difference between someone who's chronically brain, from a bioplasticity perspective, has become used to having this response in response to a bunch of triggers. And migraines are a response that happens, and sometimes the more you get them, the more you get. So how do they differ? I'm just wondering that.
I couldn't even begin to answer that question.
I'll go looking.
Okay, one last question there.
Hi, thank you. I was wondering if you know of any correlation between migraine diagnoses and other brain diseases. So you talked about other medications which we have found effective in treating migraine because of other things, but I didn't notice any brain
So, I mean, epilepsy medicines are used for migraine, for example. It comes back in part to the diagnosis issue, because, for example, if you have an acute migraine attack and end up in the emergency department, they will spend a lot of time checking whether you have stroke. And so, actually, there is a real issue with trying to understand and diagnose this. And I think there are a lot of linkages. What the solid linkages are, I couldn't say. So in terms of time, I better end there, but I'd be happy to talk further if you would like to.
Okay, I'd like to ask.